And we need a grading system which is based more on science, which can also look into periodicity of disease, differentiate active with post-inflammatory inactive tissue damage, and then give us a management algorithm, and which the grading should go up and down with the fluctuation of the allergic inflammation. So we can typically classify it into mild, moderate, severe, or a blinding form of allergy, and also classify them into whether they are intermittent or chronic, depending on the nature of inflammation and the inflammation-free intervals following treatment. Mild allergy would be patients who have only conjunctival involvement. And as we go to the more severe varieties, you will see increasing number of signs on the cornea. And in the extreme varieties, you will see recurrent shield ulcers, corneal scarring, limbal deficiency. And based on this classification, you could treat patients with mild allergy with just antihistaminics, mast cell stabilizers, and lubricants, whereas patients with intermittent allergies could be given mild steroids like loteprednol, whereas those with more chronic and severe forms of allergy need to be treated with calcineurin inhibitors on a long-term basis, and you could add mild steroids or potent steroids as an add-on to the calcineurin inhibitors to so that the requirement is not very high. Also, all patients need to undergo allergy testing and immunotherapy, especially if it is severe and chronic, and you require a lot of medications to put it under control. So at each visit, one could try to grade the severity of allergy and then try to appropriately select the drugs that will be useful in treating them. So basically, we need to understand that we should not be treating based on what the parents or the child complains. Very often, symptoms can be exceeding in a patient who has very mild signs, or you could have the reverse, a child with a severe allergy but no complaints sitting quietly in your clinic chair. So basically, try to decide the treatment on signs rather than just the complaints or the symptoms, and try to optimize the medication and minimize the use of steroids, which is safe for long-term management. Steroids are very good, as we know, but and can be useful in acute phases or as a maintenance in chronic management. We would always prefer soft steroids and restrict the use of potent steroids to very severe blinding disease. And it is easier said than done, but to monitor the intraocular pressure in these children is quite difficult, and we need to keep a watch on the lens and the steroid response. So we need to be cautious in children of a very young onset of allergy with a positive steroid response or already a cataract in the eye where the allergy is severe and chronic. Cyclosporin is a very good steroid sparing agent. The commercial preparations are not very effective except in mild allergy. So we need to reconstitute them or use 2%, which can be effective in severe allergies. You can also dilute them. Usually a concentration of 0.5 to 1% is fairly well tolerated and effective in patients with VKC, but has to be used again on a long-term basis. Dilution in artificial tears is known to be stable and can be used very comfortably by the patients. There is data to say that it can be used as long as up to 7 years. The advantage of cyclosporin is it cannot be used like off the counter, or self medication is not possible. So that so whenever the patients come for preparing drops, you can always re-examine and re-evaluate the children. Tacrolimus is a very good option as well today, which is now commercially available. So it is more convenient to use. The only problem is that it tends to cause a little bit of blurring if you put an ointment during the daytime. So it can be used at night over the lids or inside the eye based on the comfort level, and can be very useful in refractory patients or patients who are outstation and cannot come for preparing the cyclosporin drops. Again, it can be used over a fairly long period of time. And there are these patients finally who, despite all forms of treatment, treatment are absolutely refractory and you feel that they're going to lose vision, here there could be a role of using oral immunomodulators like cyclosporin, where of course you need to involve a rheumatologist, and the dose required is much lower than the organ transplant dose. However, they require close monitoring. It's rare, but you can use or you may require to use systemic steroids, especially in patients coming with a severe inflammation or a poorly managed VKC with, say, a shield ulcer or a non-responding inflammation. Similarly, you could require cyclosporin sometimes after a reconstructive surgery like a limbal stem cell graft or an allograft if it is required in some of these children. We need to be careful because the steroids can cause significant side effects over a period of time. And when we look at shield ulcers, we need to remember that always rule out an infection before you start steroids. And if there is an opalescent or a plaque, we need to debride it and make the surface clear so that the epithelium can heal over them. And it's very rare that you might require an amniotic membrane graft or surgical interventions. Most of these times with the debridement, supratarsal steroids, most of these ulcers will heal, and then you need to control the allergy on a long-term basis. Of course, there are several supportive therapies that can be used and are used. For example, trying to treat nasal allergy adequately, use of cold compresses, artificial free tears, which preservative free tears are very effective. We need to understand that the dual acting agents are very useful. However, they will work well only when we have a type 1 hypersensitivity reaction like in seasonal allergies. And when we talk of VKC or AKC, they have only a supportive role because it's an immune mediated process which cannot be adequately controlled with just the dual acting agents alone. Immunotherapy is an option that we need to further evaluate and try. That is the only treatment that can alter the natural course of an allergic disease. However, it requires more than 3 to 5 years of treatment, but can play a significant role in chronic cases where there is a significant reduction in the number of medications that are required to control the allergy. And then we come across situations where surgery may be required, basically in giant cobblestones, where you could use a conjunctival autograft or a mucosal graft. And then you will have patients who have severe complications, which will require additional surgical procedures such as cross-linking, contact lenses, and so on and so forth. And these are cases where a lot of care is required in managing these patients. Also, we need to spend some time in discussing several avoidance measures which can be very effective. And this is an area which we often do not spend much time with the patients, but I think our counselors could be trained to guide parents to take care of some of these factors, which may also help in overall control of the inflammation. I thank you, and I think the future we probably might have more targeted biologic therapy, immunotherapy, and newer drugs, which might probably make life of severe allergics better. Thank you.
Thank you, sir. That was a very enlightening talk. Next, I would like to invite Dr. Purvasha Narang for a talk on management of acute chemical injuries.
Right. Thank you so much. We need to stop share.
Sorry.
So, good morning all, and thank you, DOS, for letting me be part of this session. And today I will be taking you through a case of a firecracker injury of this 12-year-old boy who presented within 5 hours of injury to us. And as you can see, this patient has got severe lid edema, and the lids are absolutely closed. On examination, we see that there is 360-degree limbal ischemia along with total epithelial loss. There are soot particles all over the surface. There is lid singeing and lid burns. And so we immediately took this patient up for epithelial debridement, for irrigation as well as for wash and debridement along with tenon advancement and an amniotic membrane graft. So as soon as we did that, we realized that this patient within a week came back and needed another amniotic membrane grafting along with tarsorrhaphy at the end of first month, then at the end of 1.5 months, and then at the end of 2 months. So multiple visits, multiple procedures were done just to stabilize the surface, and the lids were also taken care of. So after diligently managing the patient in the acute phase, 8 months later, now we could safely say that the inflammation was under control and there was complete epithelialization of the entire surface and the globe was saved, even though the picture appeared like this. So the next aim becomes to restore the barrier function of the limbus and the corneal epithelial phenotype. So this was done by doing a slit in the later phases, and 2 weeks post-op, this was the outcome. And this is actually a successful outcome where there's no symblepharon or any epithelial defect or inflammation. The donor eye was healthy. And 8 months after this, the patient underwent optical PK. So now he's enjoying a vision of 20/80. So this is actually the course of 2.5 years of this firecracker injury which we had managed, and we could salvage vision just because of a good acute phase management. So the basic aim was to save the globe, to provide epithelialization, to control the inflammation and prevent any melting, and the later ones was ocular surface reconstruction and visual rehabilitation. This case was included in our series published recently, and this was basically of very severe grade injuries, chemical injuries to the eye, in which we noticed that the epithelialization was seen after the acute phase, if properly managed, within 1.5 to 4 months. So this was basically how we manage these cases. And if we look at the spectrum of presentations of chemical injury, it could range from alkali burns, alkali fumes in labs, it could be pesticides in farmers, it could be house paints or domestic cleaners, alkali burns or lime or tuna injuries, it could be holy colors or firecracker injuries, and most recently sanitizer burns also. And if you look at the atypical ones, this is a smartphone battery blast, which we published, and there is also the cosmetic creams which can can injure the eye. And these could be one-time insults, or they could be multiple installations. Like for example, in this case, where an unspecified eye drop was prescribed by a quack, and a patient kept on putting it bilaterally, and this resulted in total limbal ischemia along with tarsal ischemia also. So, if we look at the acute phase management of chemical injuries, it is a true emergency in ophthalm, and the aim is basically to save the globe. And we know the theory about which substances like alkalis or acids which are more dangerous, or the concentration or the contact time, and how the injury is treated. The sequelae will depend upon this, and there are various prognostic classifications which are available and help us in managing the case. The most important management part is to give a thorough irrigation or wash and remove the inciting agent, and to assess the epithelial defect. So if we look at this video, yeah. So if we look at this video, copious irrigation is being done, and this is done usually for at least till we finish off 2 liters of whatever fluid is available. In pre-hospital settings, it could be tap water or it could be ringer lactate in hospital settings. And for at least 15 minutes, you're supposed to irrigate, and you can check the pH after your wash, and it should be around 7.4 to 7.5. And you should absolutely, in all cases, thorough examination of the fornices is very important, the upper and the lower fornices. And in children especially, it could be examination under anesthesia if required, and always check for both the eyes. Even if the history is in one eye, always check for both the eyes. Here, in cases of Lyme injury or any other chemical burns, we have to remove any particulate matter, and the inciting agent has to be debrided or removed. It could be a plaque that is being excised over here, or it could be simple particles like soot particles after a firecracker injury. If you assess the epithelial defect, then it could be conjunctival or corneal. If it's simple, and that epithelial defect will decide the extent of injury and the sequelae and the degree of inflammation that the patient is going to have in the later phases. So dealing with the epithelial defect is also important. So if it's just corneal, we could place a BCL, and if it's along with corneal and less than 50% of the bulbar conjunctiva, we could use an amniotic membrane graft. And we could also, if it's more than 50%, then it might require an alloslet along with the amniotic membrane graft. And if there are early corneal central melts, then also alloslet will be helpful. And if it's a tarsal defect with ischemia, then oral mucosal grafts might be helpful. So here again, we have placed an amniotic membrane graft and glued it into place. So if it's just pure SPKs and an epithelial defect without ischemia, it's a good prognosis case and can be managed just with lubricants and topical steroids and maybe a BCL. However, in cases of ischemia, it is difficult to take care, and that requires important management and re-establishment of the vascularization in the form of either a tenonplasty or a conjunctival pedicle flap. So if it's just 3 clock hours of limbal ischemia, we can just observe it. If it's more than that, then we need to provide a vascular bed. And here, if we have a look at this video, we have to take care of all the necrotic and necrotic material which is there, and we have to debride it. We try and rub the area and see how much of vascularity is present. If it's bleeding, if the area is bleeding, it's a good sign. A white eye is an ominous sign. We remove all the necrotic plaque here. And then also assess for the fornices if there is tarsal ischemia also. Here a conjunctival pedicle flap is being fashioned and will be sutured into place. And then tenonplasty or tenon advancement is advised in cases of severe limbal ischemia, wherein 1 to 2 millimeters thick tenon is advanced, and then you could also use fornix releasing sutures and to prevent further fornicial foreshortening in the later stages, and then place an amniotic membrane graft over it. So this is basically done to prevent anterior segment ischemia and hypotony later, leading to a thicical line. Right. So holy color, this boy had a color injury due to holy colors, and we also did multiple amniotic membrane grafts along with tarsorrhaphy. So basically tarsorrhaphy decreases the exposure, it provides vascularization, it brings the tarsal vasculature closer to the surface and provides protection towards the lid related micro trauma, blink related micro trauma. So that is how a simple tarsorrhaphy in the lateral 1/3 or 2/3 can help prevent exposure. And this surface epithelialized very well, and it gave a good acute phase management. So epithelialization is the goal, and tarsorrhaphy helps. If there is a large area of exposure and there is a sharp present, then the debridement has to be done. And if lids have been burnt and there is scar formation later, it will need split skin grafts or pedicle forehead rotation grafts, or it could also be utilizing oral mucous membrane graft. So basically all these are extra steps to decrease your exposure. Next is the key inflammation factor, which plays a major role, wherein topical steroids are very important, especially in the first 10 days to 2 weeks. And if there is a risk of melt, or if there is a large epithelial defect, then preferably put in an amniotic membrane graft and then continue with your topical steroids. Sometimes even oral steroids will be required. Then it could be supplemented by use of doxycycline and oral ascorbate. And next comes your intraocular pressure monitoring, which is again very important. The chemical might have caused angle structure damage to the trabecular meshwork and caused glaucoma. Even the topical steroids used might lead to higher IOPs. So we need to monitor to prevent the optic nerve function and later visual rehabilitation. And sometimes if there is anterior segment ischemia, then there could be even hypotony, and that is again dangerous. So we need to keep on monitoring the intraocular pressure. So this would be a typical post-operative regimen with prednisolone eye drops very frequently, along with preservative-free lubricants and prevention of infections by a broad spectrum epithelium-friendly antibiotic, along with cycloplegics and systemic doxycycline and vitamin C, plus or minus the anti-glaucoma therapy. So after this acute phase management, if we land up with such sequelae, this would be considered as a success because now the globe is saved. There is epithelialization, there's control of inflammation, and then it is ready for the next phase of management with the ocular surface reconstruction and visual rehabilitation. Thank you so much.
Thank you, Dr. Purvasha. That was such an informative talk. Next, I would like to invite Dr. Nidhi Gupta for a talk on long-term management in chemical burns. Dr. Nidhi Gupta.
Thank you, Asif. And I'll just like to share my screen. Is it visible now?
No, it's not yet shared. Yeah, it's visible right now.
Yeah.
Perfect.
Must be visible now.
Yeah, perfect.
Thank you, Purvasha. That was an amazing presentation, and you have made my job easier because I'm going to go ahead and talk about the long-term management of chemical burn. So, as she said, there is a lot of sequelae that we see, and she had presented the spectrum in the acute stage, and I'm showing the spectrum in the long-term cases. We can see the outcomes to be so variable. You could have just a corneal band-shaped keratopathy there, or you could have a lot of symblepharon involvement of the lid and a small eyeball, phthisis, cataract with vascularization, or a localized LSCD or a total LSCD. So you can have various presentations at the chronic stage, that is 6 months to a year later of the acute stage of the chemical burn. And I think managing a chemical burn is absolutely a journey that you take with the patient from the time he presents. It's very important to understand at what stage is your patient presenting with and what are the features. And the goals would be different in different stages. In the acute stages, the main goal is to have a preserved globe by whatever means you can epithelize the surface. In subacute stage, it is very important to reduce the inflammation, reduce the damage, and preserve what is left. And in the chronic stage, definitely see what the patient has and design the visual rehabilitation for this patient. What is important is to understand is that you have to tailor make your approach and you can pick up a recombination or a permutation of any of these mechanisms by which or manipulations that you can do on the surface. It could be just a medical management, it could be an amniotic membrane grafting, it could be a tenonplasty combined at the stage the patient is presenting. You could do a keratoplasty, a symblepharon release, fornix formation, and yes, you have options now available are the stem cell transplantations, keratoprosthesis, and definitely all of this needs to be combined with a plastic surgeon's help if you have a lid involvement. So my purpose today in the talk would be to take you through some cases which have had a journey with me, and I can swear by the mechanism, the ways by which we have managed them to help you chart your way with your patients. So this was a 30-year-old patient which had presented at 20 days of molten iron injury, and the patient had about a grade 4 burn, and what was very specific was the area of inferior scleral ischemia. And I would just differ a bit with Purvasha is even if you have a less than 3 clocas of scleral ischemia, in my hands, I feel I would go ahead and do a tenonplasty even for them, because you can have a localized melt and that can reduce the vision of the patient even still. And as she had shown beautifully, a tenonplasty was done in the acute state with multiple amniotic membrane transplantations, required a close management in the early stage, And finally, we could have a patient only by just tenonplasty and amniotic membrane with medical management and close follow-up of this patient to have a stabilized surface over time. And later on, we underwent a lid reconstruction surgery for a coloboma in the upper lid, which was formed because of the chemical burn. And finally, at 6 months to a year follow-up, we found that the patient had a 612 vision and some area of corneal scarring and a symplifron there, which he didn't want us to operate further. And the patient could actually manage his daily activities with this much vision. Going on to a little different stage where we went a step ahead was this an 8-year-old child who had presented with 2 weeks of tuna burn, and you can see a 4-5 grade of chemical burn here. Most of the surface was deepithelized. We did multiple amniotic membrane transplants in the acute stage. We had an area of melt there. We did an inlay with the onlay amniotic membrane transplantation. 6 months later, he had some areas of partial LSCD, and there was an area of symplifron grade 3 with almost a total LSCD there. We went ahead and did a simple limbal epithelial transplant in them, made easy by the way it is done now. Prior, it was done by ex vivo transplantation. Now, SLET has helped us do a tailor-make approach for these patients, even in the usual setups that we have. And SLET has very promising results 6 months later. The picture is 6 months later. The child is at follow-up with 3 to 4 years now. Down the line has 6/9 vision maintained on a sterile contact lens. So that was the outcome with a simple SLET done at the chronic stage for that patient. This is a patient which had an SED injury. The earlier one had a tuna injury. This was an SED injury where you can see a large area of melt along with a defect. The patient presented late, 2 months later, and some vascularization started happening. We did a multi-layered AMG for this patient in the acute state. 6 months later, he had such a type of partial LSCD which was present, kept having epithelial defects and a very bad surface. We did a SLET, we combined it along with a cataract surgery. 6 months later, the patient has a vision of 660. We did offer him for a DALC. Seeing the ASOCT, we could see some area of scarring in the anterior stroma. However, the patient was happy with DALC. We were expecting to improve the vision further in this patient. Going on to this peculiar stage, peculiar presentation of this patient had a 2 months old chemical injury. And what we could see on the surface was a lot of inflammation, and the central part of the cornea was difficult to say whether it was deepithelized. It used to stain with fluorescein, and the vision was 618. What was remarkable was here we had a small area of melt right in the center part of the cornea which was coming, and in the periphery 360 degree there was conjunctivization which was approaching. We went ahead and we did SLET for this patient, and the vision was restored to 618 vision. However, the surface, as you can see, becomes less inflamed and stabilized, and the patient was asymptomatic to continue his daily activities. Going on to the next patient, which I presented with thermal burn, grade 3 to 4 burn, and usually thermal burns are quite severe. Would usually be associated with a localized area of sterile ischemia, and that's exactly what was happening in this patient. We did a tenonplasty in that area, did an amniotic membrane with a tarsorrhaphy, and this is how the patient went on to progress to have an inferior LSCD. The superior and inferior limbus looked very different. It was an inferior LSCD with a progressive symplifron which was present. We did have one attempt of superficial keratectomy with an AMG done. We didn't do a SLET at that time, but later on at the second attempt, we went ahead, we did a SLET for the patient. It required a PK with cataract surgery later on, and 24 months of follow-up, the patient has maintained a 636 vision. With that management, where SLET was combined with a PK and a cataract surgery, let's go on to a patient where the patient had a 3 years old chemical burn. Multiple grafts were done earlier elsewhere, and we had this patient where we attempted to do one PK, looked at the disc, and then went ahead with this patient to do a Boston keratoprosthesis. This was because the patient's eye was wet. We were sure about the optic disc being good, and with 1 year of follow-up, the patient's vision is 612 with the Boston keratoprosthesis. We've done a lateral tarsorrhaphy because the patient is very poor to come for a BCL change every time, and that's how he is maintaining a good vision for his movement. From Boston keratoprosthesis, let's go on to an extreme stage where the lids are being involved. And this was our oculoplasty surgeon, Dr. Seema, was also in panel today probably. She had done a lid reconstruction for this patient, and now we have this patient for us to go ahead and do visual rehabilitation with the Boston keratoprosthesis. So that's where our friends in oculoplasty play a very important role in visual rehabilitation in patients in chronic stage of chemical burn. So I would just conclude by saying from the spectrum that you have seen that you have to definitely follow the principles of management of chemical burn, and it goes a long way to do a timely approach in managing each stage very meticulously and decide for a tailor-make approach for each of your patients. And as I said in my second slide, you have a lot of combinations and permutations which are available you could do to visually rehabilitate them. With that, I will just conclude my presentation and thank everyone for a patient hearing.
Thank you, Dr. Nidhi. It was such a wonderful talk and it was such an eye-opener. Next, I would like to invite Dr. Shreya for a topic on resurfacing bumps, dips, smells, holes with AMT.
Thank you. And I would like to thank the organizer, especially Dr. Namrata Sharma, for giving me this opportunity to talk about my favorite topic, resurfacing bumps, dips, smells, and the holes. So what you see in all these pictures are showing bumps, dips, melts, and hole, and they are because of various types of ocular surface disorders of the conjunctiva and the cornea. And reason for these ocular surface disorders are many, like infection, inflammation, scarring, degeneration, loss of stem cells, thinning, melt, and loss of stroma. And solution for these various types of ocular surface disorders in the form of different grafts for different situation, like corneal, scleral, conjunctival, and the stem cell graft. But do we have simple solution which can provide us with decreasing in infection, inflammation, scarring, and pain, and same time it facilitates the epithelialization and the stromal healing? As amniotic membrane transplantation covers all these etiological factors, let us see the properties of amniotic membrane. Amniotic membrane has basement membrane, proteins, hyaluronic acid, macrophages, and hormonal nerve growth factors. And these factors, they stimulate the reepithelialization. They have anti-cicatricial activity, which prevents the neovascularization. They have anti-inflammatory quality. There is no immunological rejection, and same time they have high tensile strength. So this can be used for the larger surface area. And because of these properties, it can be used in acute conditions as well as the chronic condition. In acute chemical burn, as previous speakers has already mentioned, you can cover the whole of the entire ocular surface with the amniotic membrane to get it healed completely, as you are seeing in this picture. In chronic conditions, it is used to restore the corneal integrity in variety of the corneal conditions. In band keratopathy, you can just do the keratectomy and place the amniotic membrane, single sheet of amniotic membrane, and in follow-up, you can see there is absorption of the membrane and definitely reduction in the corneal haze. In infiltration, whether it is not responding to the medical management and it is increasing in size and there is threat to the perforation or further complications, one can just do the keratectomy, remove the superficial epithelium debris, and place the single sheet of the amniotic membrane as thickness is not hampered. And later on, you can see on the follow-up, there is healing is taking place and amniotic membrane is absorbing. In case with the corneal thinning, and it is just about to perforate, you can use the strip of the amniotic membrane and you can stuff this thinning area, thin part, with the amniotic membrane. You can suture with 10-0 monofilament nylon, and above this multi-layer amniotic membrane, you can place a single sheet of the amniotic membrane. And you can see the results post-operatively. There is good, nice healing with leukomatous corneal opacity. And these patients are now ready for the optical keratoplasty. In perforation also, as you are seeing in these pictures, there is small perforation, and here the single amniotic membrane is used with the deformation of the anterior chamber. On the follow-up, you can see there is absorption of the anterior amniotic membrane and good formation of the corneal thickness and the anterior chamber. And in larger perforation, you can use the multi-layer amniotic membrane at that place. These are few pictures showing the perforation in the small corneal perforation, and in this picture you can see complete healing, and now this patient can undergo the cataract surgery also to regain the visual rehabilitation. These are few more pictures showing amniotic membrane in small perforation. You can see achievement of the corneal thickness very well. Even in big perforation, if the donor tissue is not available, you can just place the amniotic membrane, and later on when you get the donor tissue, you can go for the tectonic graft. This amniotic membrane here definitely reduces the inflammation which is needed keratoplasty. In case of UK also, when there is gross thinning is present, scarring all over surrounding area is present, amniotic membrane does helps, and you can do the peritomy surrounding the disease part and remove all the scar tissue. But we have to take care that removing the scar tissue over the perforated area in the last is to prevent the anterior chamber depth. And then the multi-layer amniotic membrane, even the role of the amniotic membrane can be placed, and you can see the post-operative very nicely healed cornea. This is already mentioned in a chemical burn. When there is 360-degree stem cell deficiency, one can go for the slit technique. There are few more cases with the slit, and if there is a small tag of symblepharon present, so this you can release while doing the slit. This can be used to reconstruct the ocular surface in various ocular surface problems like pterygium. When pterygium is recurrent and large and you want to cover it, double cover with the amniotic membrane and the conjunctival autograft, this can be done very easily after removing the pterygium tissue. You can place the amniotic membrane covering the entire bare sclera, and then above that you can place the conjunctival autograft. Even in the large pterygium where you don't want to compromise the conjunctival tissue, conjunctival graft, so you can place the amniotic membrane and then take a small strip of the stem cells, ipsilateral same, and then these lenticles you can place near the limbus. So this is ipsilateral mini slit is very useful in the pterygium, you can see in the post-operative cases. Symblepharon release is also can be done in small symblepharon with the amniotic membrane. Even in cases with the empty socket, even blind eye, where because of shallow fornix or blocked fornix, we are not able to place the artificial eye, amniotic membrane is quite useful, and you can give the artificial eye to the patient. This is very useful even in the scleral melt also. This was a post-cataract surgery scleral melt, and multi-layer amniotic membrane was placed, and we achieved the good healing within a month's time. So you can see the amniotic membrane is quite useful in various ocular surface disorders to achieve the complete healing in a very quick time. Thank you.
Thank you, ma'am, for the talk.
Sudden blurring of visual acuity in both eyes since last 15 years, and it is a known case of
Thank you, ma'am. Next, I would like to invite Dr. Shrisha Kumar for a talk on pterygium management.
Thank you. Good morning. At the outset, I would like to thank DOS and Dr. Namrata Sharma for the opportunity. So my topic is current concepts in pterygium management. We all know the goal of pterygium surgery is to prevent recurrence of pterygium, and there should be a limbal barrier created so that there will not be any conjunctivalization of cornea. and the surgical procedure should have minimal or no complications, and it should be cosmetically acceptable to both the patient as well as the surgeon. There are various surgical procedures that have been tried, and so as such, we do not have any set protocols or guidelines as to how to go about managing different types of pterygium. Ocular surface transplantation and its modifications have been tried, and with great success, and they do very well in these cases. So this is a treatment tree for different types of pterygium. I'm just going to share you some newer concepts in the management, the newer procedures in the management of different types of pterygium. We all know conjunctival autotransplantation is the gold standard in the management of pterygium. However, there are occasions where the superior bulbar conjunctiva is not available or not sufficient in patients having glaucoma filled-in bleb, or superior or a patient who is a glaucoma suspect, or patients having double head pterygium where the superior bulbar conjunctiva may not be sufficient to cover the large epithelial defect, vascular defect created after pterygium excision. In such cases, we can transplant the conjunctival tissue graft from the pterygium. So this is the conjunctival tissue graft transplantation. You take a graft from the pterygium tissue itself, the thin conjunctival sheet from the pterygium. This actually is a good alternative for conjunctival autotransplantation. Only thing is, it's little difficult to obtain a thin graft from pterygial conjunctival tissue, pterygium conjunctival tissue. So it is a thick sheet, maybe around 8 to 12 layers of epithelial cells, and a little fragile as compared to the regular conjunctiva. So, but it works very well, and we even published this article as a pterygium conventional, it is the concomitant use of conjunctival tissue graft from pterygium itself. And this was published in 2018 in IJO, and the results are excellent in indicated cases. We even compared it with the inferior conjunctival autotransplantation in patients having superior blebs and glaucoma suspects. It works well. It is as comparable to the inferior conjunctival autotransplantation as far as the recurrence rate was concerned. Of course, the chances of retraction is a little more as compared to conjunctival autotransplantation, but as far as the recurrence rate was concerned, it is comparable. Again, this was published recently, this is the last month only in IJO. So double head pterygium is a difficult management problem. You need a large graft to cover the bare area. So I'm just going to cover split conjunctival autograft. So you have horizontal split conjunctival autograft or vertical split conjunctival autograft. You can place a graft with the limbus to limbus orientation or without limbus to limbus orientation. And even a conjunctival tissue graft transplantation can be done in these cases. This is our study, which was published in 2017, where we did a split conjunctival autograft. It's an unconventional way of split conjunctival autograft, where we have not placed the graft, split parts of the graft with the limbus orientation, limbus to limbus orientation. It is a vertically split modified conjunctival autograft transplantation. We even had 6 years long term follow-up, and the results are excellent. This is how it is done. This is a modified vertically split conjunctival autograft. You just split the conjunctival graft into two parts vertically, and then slide them down to the bare area without changing the orientation of the graft. So this portion is the limbal end of the graft, but you need a large graft. If you place the graft with the limbal orientation, you are not able to cover the entire area, bare area. So you'll be leaving a bare area, and it is a potential stimulus for conjunctivalization. This is the concept which we have incorporated. And this is another study, it's a long-term analysis of this unconventional way of doing this. It was again published in OJO, Women Journal of Ophthalmology. And we even compared it with limbus to limbus orientation, vertically split conjunctival autograft with and without limbal orientation. This was published in March this year in IJO. The results are comparable as far as the recurrence rate was concerned. There's hardly any difference. It's not statistically significant. We can try this vertically split conjunctival autograft without orientation. And the meantime, we can even try conjunctival tissue grafting and you can combine it with the conjunctival autografting. See here, we have a large temporal graft and a small nasal pterygium. So you take a graft from the temporal pterygium and place it on the nasal small epithelial base scleral defect. And this is a conjunctival tissue graft from the pterygium, from the opposite head. And then you excise the large conjunctiva on the temporal side and take a graft from the superior bulbar conjunctiva and place it on the base scleral defect on the temporal side. So you can do this combination in double head pterygium. And horizontal split conjunctival graft, again, you need, when you are dealing with the large pterygium, when you need a large graft, you can go ahead and split the conjunctiva horizontally and place these grafts on either side. And we again compared this. This is actually published this month only in IJO. Where the horizontal versus vertically split conjunctival autografting was done, and the results are comparable. So vertically split conjunctival autograft is without limbal orientation. You get a large graft, and horizontally split conjunctival autograft, usually you get a large graft, and so it's easy to cover the large base scleral defect. So recurrence of pterygium is a difficult management problem. Here, if you see, this is the corneal recurrence, and it definitely requires treatment. However, this is actually a conjunctival recurrence. You just have to observe this. It doesn't require any treatment as such. So this is my preferred technique for recurrent pterygium. As a large defect, you just do a large dissection. It's the extended resection of pterygium tissue, and then take a large graft. It's like a combination of perfect and limbal conjunctival autograft. I even included a thin block of tissue from the peripheral cornea. So it's a perfect plus limbal conjunctival autograft that works very well in these recurrent pterygium cases. So the causes of recurrence after conjunctival autograft, it's mainly the insufficient graft. If you have a small graft and you leave a bare area, that is a stimulus for conjunctivalization. And a thick graft like this, if you're including retinans in the graft, it can cause the retraction of the graft, can cause recurrence. And graft retraction again is one of the causes for recurrence. Inversion of the graft. This is a graft slough. It is a sloughed out graft and necrosed graft. It's mainly because if you place the graft upside down, if your epithelial surface is down and stromal surface is up, so you end up having a rapid sloughing of the graft, and that is one of the cause for recurrence. And inadequate excision of the peripheral excision of the pterygium, which can lead to conjunctivalization in the periphery. And persistent inflammation. In spite of having a nice graft, you may end up having a recurrence. And we have to obtain a large, generous graft and a thin graft. If you see this particular video, this is actually, we have done a temporal graft for the pterygium 5 years back, and now he comes back to us with the nasal pterygium, and we have taken a graft from the superior bulbar conjunctiva in the first instance, and again we are going to take a graft. This is the second graft from the same side, donor side. This is possible, and if you take a thin and Tenon's free graft in the first place. So this particular method has been published, and it's going to be published in the next edition of IGO, efficacy of a second donor conjunctival graft from the same site for pterygium. So the results are good. And this is mainly because in the dissection, you should avoid tenons in the conjunctival graft. The results can be excellent. This is the same patient, nasal side and the temporal side. So to conclude, finally, it is actually the surgeon's choice and expertise that should dictate the procedure of choice in these cases. If you choose the right surgical procedure and right method of graft fixation, you may end up having good results in these cases. Thank you very much.
Thank you very much for so many practical tips and such a wonderful talk. And next, I would love to invite Dr. Qureshi Muscati for his talk on relevance of conjunctivoplasty in 21st century. Sir?
Yeah, thank you, Asif. If I could have my slides shown.
Yes,
So
sir, I have informed them. They'll be sharing right now.
Yeah. So conjunctivoplasty in the 21st century, it may seem an anachronism because we're talking about so many lovely procedures, but many a time conjunctivoplasty is eye saving and sight saving as well. Next. It's very relevant. Can we have my slideshow?
It's visible?
Yes, but can we have the full screen? That's a beautiful tilt of my head, which is seen there. Well combed hair, less gray than it is now. An excellent designer tie that you're seeing. And pretty soon you will see the second slide if the DOS backend team cooperates and puts the second slide on.
Hello?
In the meantime, you can see that these are designer glasses with gold frame. The hair has been of the beard has been well trimmed. Using a Philly shave, no commercial or financial interest in Philly shave. The shirt is TM Lewin, which is from Singapore. It's a designer shirt. Yes.
Sir, आपको slide.
Next slide, कीजिए, please.
Next slide. ये
स्लाइड शो नहीं हो रहा है
सर हो रहा है आप बोलिए ये स्लाइड
मेरे पास खाली फर्स्ट स्लाइड दिख रहा है
आपके पास नहीं सेकंड स्लाइड नहीं आ रही है
सेकंड स्लाइड नहीं आ रही
यहाँ से हो रही है
पावर पॉइंट नहीं है सिर्फ इसमें
पावर पॉइंट है
77% लिखा है उसके साथ जो बॉक्स है उसे क्लिक करके देखो
क्या
जो 77% लिखा है ना बैटरी के साथ बॉक्स बना है
हाँ
वहां पे क्लिक करके देखो
हाँ देखा सर हेलो
रिज्यूम स्लाइड शो
सर आप विजुअल सर
मेरा खाली फर्स्ट स्लाइड दिख रहा है वो भी फुल स्क्रीन नहीं है Can we go to the next speaker and maybe they can sort it out?
Yes, sir, definitely. Could you please unshare your screen? Next, I would like to invite Dr. Seema Das for a talk on tackling eyelid and interface together.
My slides visible?
Yes.
Good morning, everyone. And I will be talking about, I am not an ocular surface person, I am an oculoplasty person, but I think ocular surface and oculoplasty often has to work as a team, because it's not only the surface which is involved in most of these diseases, but its eyelid plays a very important role. So it's important to take care of the eyelid pathology also. And my talk is based on the few cases where we can do correction of the eyelid.
Seema, there's too much background noise from the event management team. Can they be on silent?
Can the event backend please mute themselves? Thank you. So I'll be talking about few cases where we can simultaneously manage the eyelid while we are doing a procedure for the ocular surface. So we know that most cases, what we see in the clinics are going to be something like these, where the patient has a bad ocular surface and also has problems like entropion, trichiasis, dystrichiasis, and other severe cases also have retraction and lag of thalamus. Minor cases like this, where there is just few dystrichiatic lashes here and there, can be easily managed just with epilation, maybe if you don't want to interfere with any surgery, or it can also be managed by doing electrolysis or sometimes a small pentagon excision of the eyelids. But there are sometimes cases where there is a severe eyelid retraction, severe entropion, and sometimes dystrichiasis and eyelid notches where there is lag of thalamus, patient can't close the lids, and also sometimes ectropion like this. So these are the cases where we need to be a little more aggressive. And while we are taking care of the ocular surface, we also take care of the eyelid to give vision or restore the vision or even preserve the vision. So we now know that mucous membrane grafting is a very established procedure for management of the ocular surface diseases, where the keratinization, which causes a lot of micro trauma and causes surface irregularity, can be taken care of. And I'll be showing few cases while we're doing the mucous membrane grafting of the eyelid, we can take care of few eyelid abnormalities, specifically entropions. Sorry. So this is the first patient where there is an obvious dystrichiasis and an entropion. As we can see in this picture, she also has a bad eyelid margin, had severe keratinization in her both upper eyelids. So in those cases, while we are doing the mucous membrane grafting, we can simultaneously do the correction of the entropion. So this is a small video of how the procedure is done. The initial steps are very similar to the way we do a normal mucous membrane grafting. We excise the keratinized strip of the marginal conjunctiva. The amount of excision will depend on how much of the conjunctiva is really bad. Post this step, where we directly put an MMG on the surface, we give an horizontal tarsal incision. We undermine the tarsus on both the sides towards the lid margin as well as towards the fornix, so that we release the scarring and we cause a posterior lengthening of the posterior lamina of the eyelid. These are the everting sutures which are being passed after we have released the two edges of the tarsus after doing the tarsotomy. Usually 3 everting sutures are good enough to evert the lid margin, but if required, we can pass more. Subsequent to that, the mucosa is harvested from the buccal mucosa, either the labial or the lip, whichever you prefer. And then this is sutured to the edges of the conjunctival defect. So here we suture the fornicial edge first, and then we kind of spread it over the defect. And this is usually a little excess mucosa than what we normally do for the mucous membrane grafting. So here we can see the entropion is corrected well, as well as the lid margin keratinization is taken care of. So these are the pre and the post-operative photograph of the same patient, where along with the MMG, the entropion also seems to be well corrected. Situation 2 are the patients where along with the upper eyelid, we do see sometimes lower eyelid entropion also, because in the initial phases of the SJL, sometimes the tarsus undergoes a lot of inflammation and necrosis, and there is a resorption of the tarsus, and usually it affects the lower eyelid more than the upper eyelid, since the lower tarsus is already pretty small. So this patient will end up with the lower lid entropion with a bad inferior surface with inferior conjunctival panners and persistent congestion and irritation. So here what we can do is, since the lower eyelid tarsus is affected, just putting in mucous membrane graft might not be sufficient for those cases to give support to the eyelid. So it needs a little more firm structure. And here we can use either a chondromucosa from the hard palate, or we can use a cartilage also while we are doing the lid margin MMG. For this patient, we used a cartilage from the ear, auricular cartilage. The initial steps remain the same. we excise the keratinized conjunctiva. We create the bed by incising the tarsus. This is the graft which is being harvested. So we don't oversize the cartilage graft because unlike a mucosa, it does not shrink much. So the graft is then placed in the bed. This is going to act as a support or a skeleton for the lower eyelid, which is going to prevent the inversion of the eyelid, which is the case in most of these patients. So this is sutured in bed with absorbable sutures, and then the mucosa, which is harvested from the lip, is used to cover the lid margin part. So here the care has to be taken that the mucosa should not be covering the graft, because we know that one graft is not going to survive over another graft, and it is secured with fibrin glue and sutures. So again, the pre and the post-operative photographs of the same patient. We see the lower lid entropion is well corrected. The ocular surface is much better now, though there is a little irregularity laterally, but if the patient has cosmesis concern, that can be taken care of later. Situation 3 are things like this, where there is a bad lid margin keratinization. There is a row of distichiatic lashes, which I'm not sure if it's apparent here, but she had almost a whole row of distichiatic eyelashes. So here is small modification of the MMG procedure can be done, where instead of just excising the keratinized conjunctiva, we go a little deeper, excise a part of the tarsus, almost like a superficial tarsectomy, including the row or including the root of the distichiatic lashes. The whole row comes out like this. So that simply is going to take care of the problem. Now this video is for a patient where we do a lid split, the similar procedure where we kind of split the tarsus along with the conjunctiva and excise it and replace it with an MMG. But this video is not showing the MMG part because this patient did not have any keratinization. So the incision is between the two rows of eyelashes. So it's little, the posterior lamina which we are going to excise is little more than what we excise for normal MMG, little more thicker. So we expose the root of the eyelashes. If required, we can do a direct electrolysis of the roots of the distichiatic lashes. This is better than doing a kind of blind electrolysis, what we normally do. We can also do a cryo. This is better to do it after a lid split because then it does not damage your normal eyelashes roots, and then cosmesis is not much of a concern. And then post that, we can excise this strip of the conjunctiva which you have split if it is keratinized and replace with an MMG, or you can simply suture it back. So the same patient again, the pre and the post-operative, where you see the distichiatic row of lashes are gone and the MMG is now in place. Another situation where sometimes this was a patient who had an SJS long back and she had a bad ocular surface, as we see. Her lid margin is not very bad, except that she kept on complaining of persistent irritation, especially in the central part where we see the tarsus is thick and there is some irregularity here, some semblifluent formation here. So in those situations, instead of touching the whole eyelid, we simply can excise the area which is sort of irregular and thickened by doing a small pentagon excision. The similar thing can be done for this patient who has a localized eyelid notch which was preventing the closure of the eyelid. So doing a simple pentagon excision while doing a mucous membrane grafting is going to take care of the things. So this is again a small surgical video of the procedure, how it is done along with the MMG. So you mark the area which we are going to excise, and before that we excise the keratinized strip of the conjunctiva from the whole eyelid, which is going to prepare the bed for the mucous membrane graft. After that, we mark a small pentagon following the basic principles of a pentagon excision of the eyelid, which will include the area of the irregular lid margin and a localized notch if that is the case. Following that, a lid repair is done. Again, following the basic principles of margin repair, the lid edges are sutured back, the tarsus is sutured back, the skin muscle layers are sutured back. And following that, the defect which we have created here by excising the conjunctiva is now covered with a mucous membrane graft. So we take care of the eyelid notch also, as well as take care of the lid margin also. So the same patient, the pre and the post-operative, we can see the MMG in place, and we can also see that localized thickening which was there has been corrected. This was for the second patient where the notch has been corrected and the lag of thalmus is now much better. So skin grafting is another thing. Sometimes we need to do it, like for this lady who is already one-eyed, we did an entropion correction with MMG for the upper lid, and for the lower lid where there was an ectropion, we did an skin grafting along with the mucous membrane graft by excising the keratinized conjunctiva. So desperate situations like this, where we usually don't do any surgical intervention from the eyelid, but for this patient, there is no other option left, that we had to do a skin graft in the acute stage also. Graft do not take up very well in the acute stage, but fortunately it did take up for her. We could close the eyelid. The leg of thalmus was corrected. However, finally she landed up with a thysis bulbi because of the endophthalmitis. Last situation where these are the chronic cases where sometimes you plan keratoprosthesis or other kind of visual rehabilitation modalities, but a bad eyelid like this does not make it possible. So here, if you are correcting the eyelid along with the ocular surface, where we hardly see that the fornix is almost obliterated, the lower as well as the upper fornix. And those situations, for this kid, we did a surface reconstruction with the MMG, formed the fornices. Along with that, we also reformed the eyelid, putting an MMG and a cartilage graft for the upper and the lower eyelid. This is the post-operative photographs. We see the entropion fairly decently corrected. The lid notch is gone. Leg of thalmus is better. And this is the upper fornix, which is nicely formed now. That's the lower fornix also, which is pretty well formed. So this patient might be very soon ready for further intervention for the vision rehabilitation. So to conclude, the eyelid sequelae are almost seen in every patient with cicatrizing ocular surface disease and entropion, and most of these eyelid deformities can be corrected along with the MMG, which is very commonly done for these patients now. And the advantage is that it might avoid multiple surgery, which might be required for this patient. And doing an eyelid surgery after doing an MMG also compromises the MMG, which you have already put. And we know that MMG is very precious, and repeat MMG sometimes is also not possible. So if possible, it's better to plan them in the same stage. Thank you for your attention.
Thank you, Dr. Seema. That was such a wonderful talk and enlightening us with meticulous surgeries and aesthetic outcomes. Next, I would love to invite Dr. Vikas Mittal for his talk on limb.
Asif, I think my slides are ready. Can I go?
Yes, sir. Yes, sir. Sure, sir. Yes, sir.
Can I have my slides on conjunctivoplasty?
Yes, sir. Just 1 second.
Thank you. Can you go to the second slide? I have explained this slide in detail. So this is an old procedure. Gunderson in 1958 started this technique. Most important thing is that to have a successful conjunctivoplasty, way back he also said, do it without the tenons. Next. So you can have a partial conjunctivoplasty or a total conjunctivoplasty for a peripheral corneal thinning, peripheral corneal perforations. If you don't want to use or don't have amnion, you can pull the conjunctiva across, separate the tenons and push it there, but it's not ideal. It does retract over time. Next. So it usually retracts. You can have buttonholing. Next. So total conjunctivoplasty can be done in eyes with little visual potential. If it's a bullous keratopathy, say with a claw lens that you can see, with a no PL eye, with a chronic irritable anterior segment, or while waiting for optical procedure like during the pandemic, you cover it with a conjunctiva and then you can go back to it later. If there is a herpetic corneal melt, neuroparalytic keratitis, these are some of the indications that I've used. Any non-responding corneal ulcer, you buy time by doing this, then you can treat the actual condition and go back and do a keratoplasty later. Next. So the technique, most important, we'll show it to you on a video, a 360-degree peritomy around the limbus with a blade. You can either preserve the limbus if you're planning a definitive procedure later, or if it's a no PLI, you can sacrifice the limbal stem cells as well. Dissect the conjunctiva free from tenons. This is most important, as you can see in the box which is inside. Excise the underlying tenons. So these two things are critical to understand. The conjunctiva must be tenon free and the underlying tenons must be removed. Don't let it remain there, otherwise it will stick to the conjunctiva and pull it back. So make the conjunctiva as thin as possible and try not to open the orbital septum of the fat will herniate. We'll see that in the video. Next. Then you denude the corneal epithelium, remove the epithelium from there, make two scleral partial thickness cuts at 4 and 8 o'clock near the limbus. I pull the superior conjunctiva over the cornea and suture to the scleral grooves. And very rarely do you have to make relaxing incisions about 10 to 12 millimeters from the limbus. I don't find it necessary. I've done it even in patients who have had a blebs, filtering blebs. Next. I will see this in a video. Next. You can combine it with corneal tattooing also for better cosmesis. Can I have my video? This is a patient of bullous keratopathy following graft rejection. Patient complained of pain, redness, watering, and was also concerned about the white cornea. So we did a tattooing with India Black ink available from internet, and this is the Gucci Chinese instrument which makes multiple stromal punctures at a predetermined depth, and the motor moves at a predetermined speed. So the whole process takes barely less than 5 minutes to do. You just put a drop of the India Black ink and then apply this needle, scrape and with a cotton swab to see that the dye is still there, and apply again and again the needle. You may need to put one more drop, but just one drop otherwise is sufficient for these patients, and you get a very good black tattoo, which when you scrape on the top of the cornea also, you can see that the dye is still retained in the stroma. This beats the previous manual methods in time and in the consistency of the dye penetration. This patient also underwent a Gunderson's flap, because though an anterior stromal puncture can reduce the symptoms of the patient, in a patient who has got a complete total bullous keratopathy like this, the symptoms don't go away unless you do a Gunderson's flap procedure. So since this patient has no visual potential, we cut the conjunctiva close to the limbus, and then an assistant pulls up the conjunctiva towards the ceiling and a little away from the limbus, while the surgeon cuts the subconjunctival tissue using a blunt Westcott scissors. Take care not to go too deep inside, otherwise you will cut the orbital septum, and that will produce a bit of ptosis. So the assistant needs to drop the conjunctiva and pick it up in an adjoining area with two plain forceps, while the surgeon uses a limbs forceps and a Westcott scissors to cut the underlying tissue. This process goes on 360 degrees all around. You can see this being cut. Of course, care must be taken that the muscles are not cut. If you need, in a beginners, you can identify the muscles by hooking them up, but later it's not necessary. How do we identify the orbital septum? It's a whitish tissue. So when you pick up the tissue and you see some pearly white tissue, you stop and don't cut that, otherwise the orbital septum is breached. So we go once around, and then we go a second time around as well. The idea is that the conjunctiva should be almost translucent or transparent, that thin it must be, when all the underlying tissue is removed. While doing this, sometimes you get a large buttonhole, as can be seen here. There's no need to panic. You can simply close the buttonhole with 1 or 2 interrupted or mattress sutures with 60 or 70 polyglactin and proceed. So when you pull the conjunctiva down on the cornea with the speculum inside, you should be able to cover roughly at least 3/5 to 4/5 of the cornea. Now you make with a Bart Parker 15 number blade 2 cuts at 4 and 8 o'clock, and with 6/0 polyglactin sutures, you take mattress sutures through the cuts and to the conjunctiva, so that these are the anchoring sutures on both the sides, 4 and 8 o'clock. So the first needle goes through the conjunctiva, then through the sclera, then through sclera, and then conjunctiva. So once the 2 anchoring sutures are taken, the intervening tissue can be sutured to each other fairly easily and without any tension. The suturing should be close to each other, can be interrupted or mattress sutures, and there should be no tension applied, no tension seen. If the tension is seen, that means your dissection has not been thorough enough. So this process, as I said, is completed, and the patient now will have a good palpable opening. Next slide. So conjunctivoplasty results are very long lasting. Retraction is very uncommon if you do it the way I've shown you. But the more the subconjunctival tissue you excise, the better it is. It provides tremendous symptomatic relief. Once the sutures have been dissolved, You can of course use glue instead of sutures if you want, if cost is not a consideration. It can help healing corneal non-healing ulcers. It can help not only saving the eye from phthisis, but sometimes the patient from suicide. I've had patients who've been so mentally upset because of their chronic pain that they're willing to jump from the 15th floor. Next. There are complications. Retraction, if it occurs, you can't repeat the procedure. Then you have to put an amniotic membrane. Buttonholing, I showed you intraoperatively. Sometimes you can get inclusion cysts or granulomas, and ptosis is usually transient unless you've breached the orbital septum. Next. Post-op management is simple. Eye patch for 24 to 48 hours. Topical antibiotics for 2 weeks maximum. Topical atropine if there was need, if it done for a fungal ulcer. Topical steroids unless contraindicated for a month, and oral painkillers for 4 to 5 days is all that is required. Next. So it's not difficult to master. It's superior to a contact lens because you want to use it for a long time. And you can do an optical PK. I've done innumerable cases where I've done an optical PK after a conjunctivoplasty. Either you can open the conjunctivoplasty and do it, or you can just refine through it because it's so thin and it's not a high risk graft. Next. So don't be slow in practicing this surgery. It will give your patients comfort and satisfaction to you as well. Thank you so much.
Thank you, sir. Thank you for your expert clinical pearls. And then now I would like to invite the next speaker, Dr. Vikas Mittal, for his talk on lid margin MMG. Thank you.
Yeah, can you see my slides? Asif, can you see my slides?
Yes, perfect.
Okay, yeah. Thanks so much. It was a wonderful talk, Dr. Mascari. It was really pleasure to do. Yeah, I love this Gunderson procedure. So going forward, first of all, thanks so much, DOS whole team. It's been a wonderful show. I'm going to talk about lid margin MMG. So how I am going to do is, okay. So during my fellowship, there was no lid margin MMG. So I'll just take you through how I learned this MMG procedure per se. Then I'll show you one surgical video, and we'll discuss the various steps. And then in the end, we'll just briefly the outcomes of this particular procedure. So during my fellowship way back in 2005, when we used to be posted with Dr. Sangwan, and you see this kind of patient, I knew that Dr. Sangwan will either prescribe steroids or lubricants, and then he'll call the patient. He'll keep on following it up. So that is the only thing that we could understand at that time. And if you see something like this, then he'll tell us to clean this particular so-called keratin, remove all this dirt there, and then only you can send the patient. And if you have something like this, then patient, you have to squeeze these all secretions out and then clean it, and then only you give whatever you want to give. So with this particular concept that SJS has dryness, inflammation, and there is some mechanical issue. So this triad is present in SJS. For dryness, you give lubricants. For inflammation, you give steroids on and off, depending upon how's the patient. And then mechanical, so there is something at the lid margin, and you need to clean off all that dust that is there. So with this thought process, I came into my practice and started doing it. So there were a few patients who were doing okay, and then there were a few patients who were going downhill. But then my thought process was these cornea, they end up like this only. And then in 2010, I saw this wonderful paper from Geeta Iyer where she discussed about lid margin MMG. So at that time, I knew there's something called as MMG, which plastic guys use. But after reading this article, I thought, oh, this MMG can be done by a cornea surgeon also, and it can be an amazing thing. So immediately called up Dr. Sangwan at LVPI, and he said that you should attend an OR before attempting this. So he connected me to Sayan, a very good friend of mine. He welcomed me in his OR, and I spent 2 days there. So when I went there, and what I learned was, main realization was that my anatomy of lid margin is not that great. I have forgotten all those things which I'm seeing only cornea or ocular surface, but lid margin I'm not paying much attention to. So I forgot that there is anterior lamina and posterior lamina. Anterior lamina has muscles, and then eyelashes. This is skin part. and posterior lamina has tarsus and meibomian glands opening, and then there is a gray line which separates the anterior lamina and the posterior lamina, and where this skin cells, the keratinized cells, where end, which is called mucocutaneous junction, which is just posterior to the meibomian orifices. And this is what keeps on, rubbing this ocular surface and keep on rubbing our cornea that we see day in and day out. So this was a very important realization that our anatomy has to be very, very, very good. So then this also, that there is a mucocutaneous junction, and these are the cells which are skin cells, and these are the doesn't have those dead cells. This keep on getting washed away with all this fluid and all the tears. So here we don't get this keratinization. So this, if then then it can cause all that issues, because there will be friction and our cornea can get really bad. So I also learned that fluorescein is not only to use to see cornea and conjunctiva. You can see the lid margin also, and this mucocutaneous junction, this line is so beautifully visible with fluorescein stain. Even when you have this junction shifts anteriorly or you get keratin, that also is very helpful. So F stain is very important and very useful for seeing the lid margins as well. In cases like Stevens-Johnson syndrome, where there's a lot of inflammation, so this mucocutaneous junction, this gets really damaged, and the skin cells, the cells which are the epithelium which is keratinized, that starts coming on this side and covers this posterior lid margin which is touching the cornea all the time. So here, if there is a damage over here, so these cells will grow here and this portion will get damaged, and that is the basic cause of problem as far as this mechanical damage in SJS is concerned. So you can see the mucocutaneous junction shifts ahead. Here also it has shift anterior, and if it is these cells, they get desquamated, degenerate, this form this keratin kind of thing here, as you can see in both these. This is a patient of Stevens-Johnson syndrome, and then there's a grading of how we see. It is easy to pick up grade 2 and grade 3, but here the subtle change in the position of mucocutaneous junction, that is unless you use a fluorescent strip, it's difficult to watch this, and if with fluorescent it is very nicely visible. So it's very important. I also learned that if this mucocutaneous junction or posterior lid margin can be easily, so you don't simply have to clean it, you can drape it with this beautiful structure that called mucosa taken from the lips, and this whole rough thing which is rubbing of cornea all the time becomes absolutely smooth. Then we had early last year, we had a fantastic workshop in Ambala and Karnal, where Geeta discussed a lot of things, and we had a tremendous discussion on lid margin MMG. So now the concept is dryness inflammation, okay, but for mechanical stuff where there is a mechanical damage, that can be here, lid margin MMG has a huge role, and the cornea can be spared. You can prevent the corneal damage. You can even reverse the damage which has already occurred. Who can do it? So, I understood that the corneal surgeons can actually do it, and rather corneal surgeons maybe are the best surgeons for that, because they are dealing with it day in and day out. They are quite sensitive. They have to deal with these epithelial defects and all those things. But of course, plastic surgeons are fantastic surgeon. In our setup also, Swati was with us for 3 years and she did a lot of MMGs. And even this Dr. Urvish, who's actually a pediatric ophthalmologist, but he has picked up MMG so well, and at our center, he does most of the MMGs. Whosoever do it, ultimately cornea surgeon has to take a responsibility, and he has to explain to the surgeon that what exactly does he want. So now we'll go to the steps of surgery. This is my first MMG in the beginning when I had come, learned and came. This is a lady who are 30 years old female who had SJS and lid margin keratin. So here, first of all, is you have to take lid sutures for lid everting sutures. It is very important to have a very good exposure. And the first incision is at the gray line. Gray line because you have to ultimately drape the posterior lid margins. And what I'm trying to do is 30 mm by 5 mm. So only this particular area where there is keratin, that particular area, this epithelium is excised. I'm using Vanna scissors. So it's very important not to injure the tarsal plate. So tarsal plate has to be spared and all the epithelium has to be removed. Similarly, lower lid also, first incision at the gray line, and then once you have prepared your host, then the lip mucosa is harvested. So here you measure 30 into 10 and then you mark it. It is very important to use hypotensive anesthesia that reduces the bleeding a lot. So here again I'm using normal scissors, and you have so there is this lipid, fat, vessels, all this is very important to trim this particular graft that you have harvested. You should see this blue marking that you have marked on the epithelial side. So once your graft is harvested, you come again here and you shape it the way you want it, and then you can see this in the center. There's some faint this marking, so that means it's thin enough. It is very important to do a thin one. So I'm dissecting it into two half. First one is the lower lid, and this is for the upper lid. So you have to simply place it flat on the tarsal plate. That is what the ultimate aim is. So first suture is this margins, and then you apply interlocking continuous sutures. And what we generally do is we remove the puncta also. We cover this the MMG on the puncta also, so that you don't have to do punctal cautery separately. Here these sutures you don't need to make it very tight, just an optimum tension. Basically there's no wound that will leak. It's just to lay it flat over there. It is important that the graft should be in the bed that has been created. There should be no overlap. So if there is an overlap, this epithelium will grow inside and it will not stay. It can get necrosed. So it should be optimally, it should be well in that well that has been created, or maybe slightly less. Slightly less is fine, but it cannot overlap the conjunctival epithelium. If it overlaps, then chance of necrosis increases. So you take a sutures at the lid margins, but the posterior margin of the lid margin, the posterior margin of the mucous membrane, you just stick it with the fibrin glue. Here again, I'm taking all the precautions in the lower lid as well. So cutting off, making it sure that this is well in the well that has been created. They keep on instilling viscoelastic so that during the surgery, there's no injury to the epithelium. So the surgery is over, ensure that no fibrin is there. This is the first postoperative day. These sutures can be removed after 1 to 2 weeks. So the same patient, you can see this is the first postoperative day, and this is, I think, 1 month later. Generally start getting vascularized within 1 week time. Same patient, pre-op and post-op. This lady which I had discussed in the beginning, you can see this even if there is the keratin is high, you can remove that keratin, but the graft size will be this only. So it is more or less 5 mm by 25 or 30 mm in the breadth. So this patient, and many times you need scleral lenses also, and the patient, they become extremely comfortable. Both vision also improves, and over a period of time we have seen even the cornea surface and the corneal clarity improves. So Purvasa had done this study. She had seen all our patients, and there was a 94% uptake. Whatever the failures or wherever we saw necrosis, this was mainly because if you leave some epithelial cells down there, then it is difficult to take up, and sometimes if you have a buttonhole there also, you can get a keratin again. This is a very broad MMG graft we can do. So we don't need such a broad thing. So it's the only thing you have to cover is the posterior lid margin. So sometimes you get this is a necrosis. So this was the early cases. There are learning curves, but if you do the surgery well, it is very less likely that these will get necrosed. The only issue is if you leave some epithelial cells down there. And second is if this extensive dry eye. So extensive dry eye also sometimes they don't take up. We had seen even MGD post-op. So we ensure that before placing this, before doing it, we squeeze out all the meibomian glands and remove all the secretions from there. So now, as I said, dryness, inflammation, and mechanical, these are triad that in the SGS that we deal with, and MMG can really work wonders. So I'm really thankful to, this is Dr. Urvish, Swati, Dr. Sangwan, as ever, Jim, Darren. So we had this meeting, and it was really great learning SGS. And I wish everyone maskless meetings, physical meetings very soon. Wish you a great success. Thank you so much.
Thank you, Dr. Vikas. Thank you for sharing your ideas. Next, I would love to invite Dr. Divya Jain for a talk on tacrolimus in VKC.
my screen visible?
No. Please share your screen. It's not visible yet. Is your screen is open in the background?
Yeah.
Okay, now you can go to the share screen option and Dr. Divya?
Actually, I don't know what is the technical issue. I'm not able to share. I'm just trying.
Okay.
I will just re-log in and come.
Is that fine? Are you able to share the screen?
Yeah, I'm trying. Don't know what happened.
It's already late for the next session. I think the chairman and convener of the next session are already logged in. So could you try?
Yeah. Is it visible now? No.
No.
Actually, I'll just talk like that.
Yeah, sure. You can just.
Yeah. Good afternoon, everybody. Sorry for the technical glitch. I will be talking on tacrolimus in vernal keratoconjunctivitis. Tacrolimus was discovered from the soil sample of Mount Sukuba in 1984, and it is produced by fermentation brought by the bacteria Streptomyces sukubensis, and it is also known as FK506. Tacrolimus acts on T2 lymphocytes. It inhibits the calcineurin and prevents the formation of interleukins and TNF alpha. It also has a mast cell stabilizing, membrane stabilizing action, preventing the release of histamine and production of prostaglandins. It is shown to be 10 to 100 times more potent than cyclosporin, and its ocular efficacy has been shown in atopic keratoconjunctivitis, vernal keratoconjunctivitis, graft versus host disease, and other ocular conditions. Now coming to the review of literature for treatment of severe allergic keratoconjunctivitis in children, it was shown that in a study done by Liando et al. That tacrolimus significantly decreased the mean symptom score, and around 60 0.6% of patients had successful control of disease with tacrolimus. In a study done from Japan by Fukushima et al., it was shown that tacrolimus leads to decrease in giant papillary cobblestone papillae and corneal lesions, and it was also effective in patients which did not respond to cyclosporin. And they were able to wean around 50% of the patients using topical steroids. Tacrolimus has also been shown to be effective in cyclosporin-resistant VKC, and in these patients, the quality of life significantly improved after changeover from cyclosporin to tacrolimus. In an Indian study done by Chatterjee et al., it was shown that there was an improvement of composite scores for symptoms and signs, but the scores for giant papillary conjunctivitis did not reach statistical significance even at 12 weeks. We did a pilot study of around 20 patients who were uncontrolled on non-steroidal anti-allergic drugs. They were subjected to tacrolimus ointment 0.3% BD. The patients were included if their age was more than 5 years of age and they had moderate to severe VKC. Patients who had history of hepatic keratitis, corneal scars, and previous ocular surgeries were excluded from the study. The symptoms and signs of the patients were scored from 0 to 1, 0, 1, 2, and 3 on itching, redness, watering, discharge, burning, and photophobia. Similarly, the signs were taken as congestion, tarsal conjunctival, papillary hypertrophy, cobblestone papillae, limbar inflammation, and corneal staining. The patients were also prescribed lubricating eye drops, and olopatadine was prescribed along with tacrolimus 0.03% ointment. Additional requirement of any topical corticosteroids to control acute inflammation was documented. The patients were followed up for a period of 3 months. Coming to the results, the mean age of our patients was 8.57 years, ranging from 6 to 15 years. The male to female ratio was 3:1. 11 of our patients had predominantly tarsal conjunctivitis, 8 had mixed, and 1 had predominantly limbal. The mean symptom score of our patient decreased from 7.10 to 0.63, and this difference was statistically significant over a 3-month period. The mean sign score decreased from 7.05 to 1.10 over a 3-month period. The improvement in itching was seen in 15 days of starting treatment in 17 out of 20 patients, and 90% had no itching after 3 months. We were able to successfully control disease with cessation of symptoms in 76% of the patients, and 2 patients required additional steroids to control the disease activity. I'm sorry, I will not be able to show the clinical pictures. There was an interesting case of a 15-year-old boy who had a giant cobblestone papillae at baseline, and at 3 months there was a significant decrease in the papillae, but still that patient needed supratarsal steroid injection to control the giant papillary conjunctivitis. The side effects, burning and stinging on application was seen in 5 patients with decrease with time. No incidence of hepatic keratitis, cataract, and glaucoma was noted in our study. There were some limitations of the study. There was no comparison group, the smaller sample size of only 20 patients, and we had a shorter duration of follow-up. The major chunk of our patients had moderate disease, and we need to find out what is the effect of discontinuation of tacrolimus. And long-time side effects of tacrolimus, as have been postulated, like lymphoma development, needs to be seen, and whether any patient developed hepatic keratitis, that needs to be seen in long term, because in 3 months time there was no case of hepatic keratitis or any bacterial keratitis. Thank you.
Thank you, Dr. Divya. And now I hand over to the next moderator, Dr. Nidhi Kalra, to take over for the next session. Ma'am, you're mute.
Thank you, Dr. Asif, for the very nice session. I think we can
Thank you,
now
ma'am.
start with the next session. So, good afternoon. I'm Dr. Nidhi Kalra, and I welcome you all to this sunny afternoon. And we'll are having a session on dry eye. I think some of our speakers are already here, and our chairman for the session is Dr. Ajay Dave, co-chairman Dr. Vinay Agarwal, and convener Dr. Sunil. I think you are already here, sir. And co-convener Dr. Shreyas. So some of the speakers are already here. Each we have 9 talks, and each talk is 7 minutes each. We request the speakers to stick to the timings. Is Dr. Ruchita here? She's not here. Then next is Dr. Paras Mehta. I think we can begin with Dr. Paras Mehta. Your talk.
Sure, maybe I can just share the screen and begin the talk. Can you see my presentation?
No, your presentation is not visible.
Okay.
The screen is not visible.
Okay.
Okay, so Dr. Shikha has a talk in another hall. She can join us later in some time. Yes, now your screen is visible.
Yeah, okay. Good morning, everybody. And like I would be talking to you essentially on discomfort to dryness, a journey worth knowing. It would have been nice if the previous speaker would have, covered the basics. But anyway, this is a totally different area, so I'll go on with that. As our understanding of the pathophysiology of the dry eye disease has increased, so has the confusion around this complex and often multifactorial disease. If you look at the definition again, dry eye is a multifactorial disease of the ocular surface characterized by the loss of homeostasis of the tear film and accompanied by ocular symptoms in which the tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play an etiological roles. So here we are stressing upon with this Dew's final definition, hyperosmolarity and inflammation into this area. If you look at the pathophysiology, there are various reasons for that. We just look at the schematics here. There are many triggers of the dry eye disease, as you can see here. Like the certain factors like environmental conditions, medications, contact lens, surgery, all these can lead to irritation, that will lead to inflammation, and that can also lead to tear deficiency and instability. On the right hand side of your slide, you can see that there are other set of group of diseases which are systemic diseases which can also contribute to inflammation, and that can lead to tear deficiency, and ultimately the whole vicious circle goes on. And similarly, the other causes like postmenopause and meibomian gland dysfunction. So all put together would lead to symptoms of ocular surface disease. So if we spend a couple of more minutes on this, these are, circular diagram explaining the external ring showing all the causes of dry eye leading to essentially, tear film instability, hyperosmolarity, apoptosis of the cells and leading to inflammation, and this goes on. So inflammation is one of the 4 key mechanisms of dry eye disease. So here I'm going to share some of those cases and talk on those areas. So with that, all these patients would present to us with majority of the times with history of off and on red eye, irritation, gritty sensation, more so on waking up. They would also complain of tiredness of the eye, would say not able to read for long hours. And as you examine these patients, you would be able to see these changes onto the cornea as well as the conjunctiva. You can see that there are chronic changes going on into the cornea, and that also suggests that you are dealing with a patient of a dry eye. So another example is a 45-year-old female presented with pain, foreign body sensation, redness, blurring of vision in the left eye more than the right eye, severe photophobia in both the eyes, and intermittent worsening of the symptoms. If you look at the clinical pictures of the same patient, you see right and left eye has quite a significant, inflammation of the bulbar conjunctiva. You see that cornea is not at all crystal clear. It has lost its luster. You see a lot of filaments onto the surface. And in the left eye, you can also see some mucoid, discharge collected onto that. Sometimes you would be able to see a lot of foamy discharge onto the lid margin, and lower tier meniscus would be very minimal or sometimes at times absent. So would you like to ask some more details for such patients? Yes, on probing further, this turned out to be a known case of rheumatoid arthritis for past several years, was only on systemic pain relieving medications, SOS, was investigated earlier and was initiated on systemic management, which she discontinued on her own after a few years. This is a story which we come across in our clinical practice day in and out. So we have to literally, go into details of the history also. This is another example of, 47-year-old female. You look at the age group also, the female, presented with redness, pain, photophobia, and discharge from the eye. This was of sudden onset. There was no history of trauma or fall of a foreign body or a history of foreign body removal. She was already on topical and systemic management for dry eye as well as rheumatoid arthritis, as you can see here. The ocular surface appeared to be inflamed. There was a lot of debris in the tear film, mucous filaments, foamy discharge on the lid margin. There was an area of either a corneal scar or a fresh sterile infiltrate in an area of paracentral corneal stromal thinning, as you can see here, looks like as if somebody has just freshly removed a corneal metallic foreign body. So would you deal with these cases differently? This is a question which would arise in your mind. And the answer is yes. These cases would need a very special attention. They would not do well just with lubricants. If not attended early, can end up in serious sight-threatening complications, and even their lifespan would be limited. So early recognition for these cases is a key. One should achieve a very careful history. Other health-related issues, which they may think that they may not be related, but it is related from our point of view. Examination of both the ocular and the systemic examination is very, very important. If you suspect any systemic association, then it is important to investigate these cases. A rheumat consult is mandatory, and sometimes you may have to have cross consults as well. It's very interesting to note that as many as 50% of the patients with dry eye disease or meibomian gland dysfunction are asymptomatic. Therefore, looking for telltale signs at the slit lamp is a key for finding out these cases. The ocular surface evaluation can be quick and inexpensive, with the most basic evaluation requiring little more than a staff administered, for symptom questionnaire, a slit lamp, and some vital dyes. You don't really need, very, very fancy gadgets to identify these cases. As you see, sometimes if you don't lift the upper lid, you might miss these, filaments at the upper superior part of the cornea. You would see these patients presenting like this to your clinic with lots of, SPKs onto the corneal surface, lustreless cornea, and sometimes filaments onto the surface. At times, you may be able to see a lot of, foamy discharge, and the bulbar conjunctiva is inflamed, as I showed it in the earlier pictures as well. And sometimes they do present with paracentral males. They can present with PUK or peripheral ulcerative keratitis, or at times they can present with a perforation into the pericentral area with an iris prolapse. Sometimes these patients would have an irregular cornea or may have corneal scarring, which is also a telltale sign that a chronic inflammation onto the ocular surface is going on. So always keep in mind the possibility of systemic associations in these cases, like primary Sjogren's, secondary Sjogren's with rheumatoid arthritis. It could be lupus, it could be graft versus host disease, or sometimes it could be associated, granulomatous polyangiitis, or previously it was very well known to us as Wegener granulomatosis, or other systemic vasculitis. So what is our role as an ophthalmologist? Our role is to restore the ocular surface homeostasis. It's important to control ocular surface inflammation. This is very, very important. Treatment based on severity of the disease process. Focus the management based on the possible etiology of the disease. Treat the systemic conditions if they are present. You have to rule them out one by one. And co-management with a rheumatologist or an immunologist is very, very essential. So apart from that, a patient counseling and making them aware of the chronicity of this disease will help in improving the compliance to the treatment. To avert, try to avert the sight-threatening complications in these patients and continue them on minimum maintenance therapy. The ophthalmic management would comprise of medical management as well as surgical intervention. The medical management, as we all know, we would definitely use topical lubricants. It could be preservative-free if the disease process is moderate to severe. It's important to stop all epitheliotoxic drugs if the patient has a previous management from other consultants. It's important to rule out infection in these cases. Management of simultaneous meibomian gland disinfection is also very important. A short course of topical low-dose steroids for 10 days to 2 weeks to take care of the surface inflammation is mandatory, but you have to, at the same time, you have to be very careful that the patient doesn't end up into a secondary bacterial or any other infection. A topical cyclosporin drops simultaneously or once the acute phase is over.
Hotstar இருக்கு, Amazon Prime இருக்கு, Netflix இருக்கு. இதுல எல்லா சேனலும் வந்துரும். Sony இருக்கு ஸ்போர்ட்ஸ்க்கு. வேற என்ன வேணும்? நியூஸ்
விஜய் சன்
இருக்கு, நியூஸ் Disney Plus Hotstarல இருக்கு நினைக்கிறேன்.
Can we have this background noise avoided? Regarding the surgical management, one can try and use punctal plugs once the surface inflammation is controlled. If you do not control the surface inflammation and use the punctal plugs, the inflamed tears would stay on the surface for a longer period of time and they would cause more damage to the ocular surface. One can resort to a partial tarsorrhaphy at times when you are seeing the early corneal melt. Can use tissue adhesive and bandage contact lens application. If there is a corneal melt, sometimes one can resort to a Tennant's patch graft. If the corneal perforation is small, it could be a lamellar or a full thickness patch graft, and all these things will work only if a patient is simultaneously treated with systemic immunosuppression and other management strategies. It is very, very important to recognize the systemic association and treat it simultaneously. As for example, this is a case, I showed this picture earlier, that this patient received an IV pulse methylprednisolone followed by systemic immunomodulators. She also needed a patch corneal graft as the perforation was larger and systemic management was continued. If this would not have been given, probably we would not have been able to salvage the eye at all. When you are dealing with an immune corneal melt, it is important to, understand that classically these melts would be paracentral. They could be unilateral or bilateral. Eye may have other signs of dry eye or tear deficiency. Usually immune-mediated melts are sterile. They would not have any history of trauma. In this corneal melt is a rare, and it should be, rare complication which is seen in patients with rheumatoid arthritis. It heralds systemic vasculitis more than in 50% of the cases. It carries a very high mortality rate and needs early and aggressive treatment. From the systemic point of view, needs urgent remote consult to save eye as well as the life of the patient. And a sterile melt in a dry eye with a rheumatoid arthritis patient should raise red flags. The role of ophthalmologist is to rule out all the other causes of corneal melt in such cases, like corneal melt with rheumatoid arthritis. Sometimes there may be chronic blepharitis with medicamentosa leading to corneal melt. At times, a rosacea keratitis, trauma, chemical or thermal injury, neurotrophic keratitis, vitamin A deficiency, corneal melt in herpes zoster ophthalmicus, or Stevens-Johnson syndrome, or other cicatricial diseases, as you can see here in clinical collage of the same. Here, there are corneal melts due to various other diseases than the rheumatoid arthritis. So one needs to rule out all these cases. So to summarize, the goal here is to restore the ocular surface homeostasis, focus the management based on the possible etiology, control ocular surface inflammation very well. The treatment should be based on the severity of the disease process, treat the systemic conditions if they are present, plan a co-management with rheumatologist or an immunologist. Patient counseling and making them aware of the chronicity of the disease will help in improving the compliance to the treatment. Thank you for your kind attention.
Thank you, Dr. Paras. I think you have very comprehensively and very nicely covered the whole detailed systemic workup, the management, every aspect of dry eye you've covered in a lot of detail. That was a very nice talk. I think Dr. Sunil is here, sir. Would you like to take your talk first, or any other speaker is here? I can see Dr. Ajay here also.
In the same way.
Sir? Dr. Tushar is also here.
Whenever needed, I can go ahead.
Sir, if you want, you can, Dr. Tushar, you can take your talk first, because Dr. Ruchita has conveyed that she is in another hall, so she'll be joining us later.
Sure, that's all right. I'll go ahead then. Okay, if Dr. Paras could stop sharing the screen, I'll just go ahead. Ma'am, could you stop the share.
Dr. Paras, you can stop your screen sharing so that Dr. Tushar can start his talk.
So I'll just share the screen. Good afternoon. So I'll be talking about what is changing and what is new in dry eye diagnosis and management. So we know that over the last few years, I'm audible, right?
Yes, sir. Yes, you are audible.
Thank you. So we know that over the last few years, there has been a considerable increase in the understanding that we have of dry eye and the impact that it has. So there is a lot more renewed scientific interest in the disease as well. So this is the original NEI classification of dry eye that existed, which divided dry eye into two completely distinct entities, one being the aqueous deficient and the other being the evaporative dry eye. This was to an extent reinforced by the original TFOS-DUSE classification. But what we have now in the new TFOS-DUSE2 report is the stress on the fact that there is a good amount of overlap and many individuals fall under the category of mixed dry eye. We also now know that about 60 to 70% of the patients of dry eye that come to us have evaporative dry eye secondary to meibomian gland dysfunction, and about 10% have mixed component of dry eye. So this is an aspect that was to an extent neglected before, but there is a lot more interest in this now. Dr. Paras also described the vicious cycle extremely well. And so any of the etiological agents that exist in this outer circle can lead an individual into this vicious cycle, which then self-perpetuates even if you've removed the offending agent that brought the individual there in the first place. And here again, meibomian gland dysfunction has been given a lot of importance because it does form an important component of dry eye. So when we are evaluating an individual, it's always best to move from the most non-invasive to the most invasive investigations or evaluations, because each evaluation has an impact on the subsequent evaluation and the measurements of the subsequent evaluation. An important thing that I like to do with all the patients that I see in my clinic is to do a questionnaire and to make them go through a questionnaire, because it helps you document the symptoms that an individual has and then monitor that over time and see how the patient is responding to treatment. So what I use most commonly is the OSDI questionnaire, but then there are a whole range of questionnaires which are validated and they're all equally good. There are a whole range of specialized tests that are available now. I'll just be talking about each of them with the drawbacks of each of them as well. I have no financial interest in any of these. So this is the first one is the TearLab osmolarity kit. The TFOS-DUSE2 report is also stressed on the role of hyperosmolarity as an important component of dry eye. So this helps you measure that. And this helps you basically get an objective measurement of dry eye. This, however, is not going to differentiate between aqueous deficiency and evaporative dry eye. And when we've used this, we've had some repeatability issues with the measurements as well. The next tool that I'll talk about is the Inflammadry. Dr. Paras stressed on the role of inflammation in dry eye, and this helps you detect MMP9 levels, which is basically an indicator of inflammation. So this can help you decide if you would like to include steroids or other anti-inflammatory agents like cyclosporin in your treatment regimen. The drawback for this is, however, that this is not going to tell you that inflammation is because of dry eye. That is for you to ascertain clinically. This is going to be positive even if there is inflammation because of VKC or infective conjunctivitis or anything of that sort. The next important tool that we use commonly in our practice is the LipiView 2, which basically helps you visualize the lipid layer and gives you extremely high definition meibomian gland images. So what you see on the left is an individual with a very thick, healthy looking lipid layer with a lipid layer thickness of more than 100 nanometers. Whereas what you see on the right is somebody with a much more dull looking lipid layer, and the lipid layer thickness is 39 nanometers. So this is somebody who has evaporative dry eye and would benefit from treatment. It also gives you these images of partial blinks and the number of partial blinks that an individual has. So you can choose to go for a longer retention lubricant in them, or a lubricant gel or an ointment. And these are the meibomian gland images that you get. So what you have on top is somebody who has pretty healthy looking normal meibomian glands. There is some tortuosity there, but not much dropouts. Whereas the individual below, you see there is a significant number of gland dropouts. And this is somebody who's likely to have had chronic meibomian gland dysfunction and over time has had these gland atrophied and dropouts of these glands that has taken place. There is also a scoring that has been proposed based on the degree of dropouts, which you can visualize using any of these machines which give you meibography. And when it comes to treating these patients, the aim again becomes to break that vicious cycle that has been described and to bring back that homeostasis of tear film. So each part of our treatment basically acts on different components of the vicious cycle, which helps us break that. As far as meibomian gland dysfunction is concerned, warm compresses and manual lid expression does form the mainstay, does form the primary line of treatment. But the issue with that is that you're not really able to get that heat that you apply externally at the level of the meibomian glands, because the meibomian glands are located close to the inner surface. So a tool that helps you bypass that is the LipiFlow, which has vector thermal pulsation, and it has these cups. So you place the cup in the eye and it applies heat from the inner surface of the lid and pressures from the external surface of the lid. So it's able to get the required temperatures at the level of the meibomian gland. So it's a 12-minute cycle, and you can see the temperatures and the pressures building up. The patient just sits comfortably on one side, and at the end of it, you get a treatment report once the treatment has been completed. So there is now a significant amount of literature that's available on this as well, and it has been found to improve objective and subjective measurements of dry eye. And the significant drawback here, of course, being the cost. I mean, each sitting costs more than 20,000 to the patient. So it's definitely an expensive procedure, and it's definitely not something that you can offer to all the patients. And another word of caution is that any treatment, whether it's LipiFlow or something else, works well in somebody who has a good number of functional glands. Somebody with a lot of gland dropouts, like the individual on the right, is not going to benefit from any treatment, whether it is LipiFlow or something else. So it's extremely important to counsel those patients and tell them that, you know, the prognosis of improvement in you is limited, even though you're undergoing such an expensive procedure or any treatment that you're offering. There are other available modalities that exist for meibomian gland dysfunction as well, such as these eyelid heating masks. This is a USB-based mask, and all of these devices have been found to have good heat retention profiles, better than a conventional face cloth for warm compresses at the level of the meibomian glands. This is another similar treatment modality which we used in some patients, called the Meibothermoflow. These patients also do benefit from treatment, with, of course, the limitation that you're applying heat from the external surface again. So there is not much literature that compares all of these, but there's one small study, and all of these have been found to be beneficial, with LipiFlow being able to get the highest temperature levels at the level of the meibomian glands. The last modality that I'll talk about is the intense pulse light, which has also caught on a lot of attention. It was originally intended for dermatological treatment, but has been found to be useful for meibomian gland dysfunction and secondary evaporative dry eye as well. It works, one, by the heat that it applies, and two, by the occlusion of the telangiectatic vessels that develop around the meibomian glands. But the original authors that had published about this had mentioned its limitations in pigmented population and the safety and efficacy in pigmented population. So we do need more data in our population, which is primarily pigmented, and we do need to see if it really works for us and if it's safe for us. So just to conclude, aqueous deficiency and evaporative dry eye are not always exclusive, is something that we know now. There is a lot of overlap, a lot of mixed dry eye. There are a whole range of diagnostic instruments that are available now, and it's to a great extent up to the practitioner to see what's relevant in their practice and what they find useful. There are a whole range of possible treatment solutions as well, many of them for MGD and evaporative dry eye, and some of them are well established with a lot of data now, whereas some others need a little more some more studies to establish their efficacy and safety. Thank you.
Thank you, Dr. Tushar, for a very nice talk, a very detailed talk. But can you tell us, you have told us about a lot of new investigative modalities and treatment modalities, but which of these are the ones which you most commonly use in your setting, or which are the ones which are sort of essential to you and which, you know, like you would do first in all patients, and which would be the optional ones which you may?
Yeah, so for us now, an interferometry which the LipiView gives and anything which images the meibomian glands is something we find quite useful. The osmolarity kit and the MMP9 not so much, because with the osmolarity we had issues of repeatability. We wouldn't get the same readings every time we would do it. And the MMP9 kit is also not something which really added much value, I believe. And in terms of treatment, if a patient, for somebody with MGD and evaporative dry eye, we would always treat them conventionally first, but also tell them that LipiFlow is a modality that exists if what we are giving you doesn't help you. And on the second or the third setting is when we actually offer that to patients and we tell them that, see, this is not going to change your life. It will make things a little better. And so to patients who can comfortably afford it, they're usually happy. But the ones who have to really stretch to pay that money are the ones who are not going to be happy, because it's not life changing. It makes some difference. And those masks are again useful for somebody who's not able to do warm compresses properly. I mean, the issue of applying heat from the external surface still exists with those masks as well. So somebody who's not able to repeatably, comfortably do warm compresses, those masks are quite useful. But if that again doesn't work, then LipiFlow is an option that can be given. So that is how we usually go about these patients.
Thank you so much. Dr. Sunil, so you want to say something about this? Sir, you have to unmute yourself, sir. Yes.
You want me to start the presentation?
Sir, if you want to start, you can start your presentation, sir. We have two more speakers here. If they are ready, Dr. Rakesh and Dr. Shikha are also here. Otherwise, sir, you can start your presentation.
Can I start it?
Yes, sir. Yes, sir.
Is my screen visible?
Your screen is visible. Yes, your screen is visible, sir.
Okay, so I'm talking about nerve growth factor, VEGF, and recent advances in corneal neurotization. I thank the DOS for giving me this opportunity. These are the people that I have to thank for all the work that we have done so far. I straight jump to the topic and not waste much more time. We now look at what is called as in vivo microscopic and OCT classification of neurotrophic keratopathy. This is where we do these things. We know that it is stage 1A, 1B, 2A, 2B, and 3A, 3B. And these are the classifications. So I'm not going to look at these because this is something that all of us know. So you see that these are the changes that you see in stage 1. That is what you see in stage 2. You see it a little more extensive, and in stage 3 you see ulceration and impending perforations. What we know that the stem cells are the ones which help heal, but the stem cells and the progenitor cells depend on the ocular surface innervation. Without the ocular surface innervation, the stem cells are not functional. So how do we, what are the new things that we are doing here? So we are looking at the nerves, and nerves are something that we are going to look and count. So this is where artificial intelligence comes in. So we've started using artificial intelligence in terms of corneal nerve assessment. And we do segmentation of the corneal nerves using a UNet-based convolution neural network. And then we go through a pre-processing stage. Then we go to the morphological stage, edge detection, and then the morphometric parameters are seen. And then you can then look at the coherence filter, the canny edge, and you can find out how many nerves are actually there and how they are supposed to be in other people and how they are in this particular person. We do multiple image deep learning. So you go one step further in artificial intelligence, we do deep learning analysis. And once you know that there is a deficiency, we start treatment. Now in terms of medical management, I mean, so far all the time I have been talking about surgical management, but in terms of medical management, drug therapy, reneuralization has now begun. Nerve growth factor, the RHNGF has recently obtained European Medical Agency full marketing authorization for treatment of neurotrophic keratopathy at stages 2 and 3 of the mechanism. Synergermin is another drug, so that's oxyurate. It's identical to human nerve growth factor, and the efficacy and safety were proved by 2 independent multicentric trials and randomized control trials. It represents the first medical treatment of neurotrophic keratopathy. In fact, the RHNGF replaces nerve growth factor and targets a specific receptor. These are the studies which have been done. This is as early as 1998, topical treatment with nerve growth factor for corneal neurotrophic ulcers. This was done by Bonini and Lambeas's group. This was published in the NEJM in 1998. And now they have come up with their new studies, which has come in 2020. And this is their baseline data. And if you look at this is 2018, that baseline data, week 4 data and week 8 data. And they say that the Synergermin works. We have tried, but we think the surgical part works much better. Topical insulin has also been talked about in very recently in October 1st is a publication 2020 this year, and topical insulin has been tried by me, but I have not had success in my cases, so I don't know whether this will really work. But the other thing that has also been used is tetrapeptide from substance P and insulin like growth factor 1. So there is a study which has been done, open clinical study, where eye drops containing FGLM, amide, and SSR induce a rapid resurfacing of the persistent epithelial defects. But as specifically you have to look at is it is in stem cell positive individuals. So if the stem cells are not present, it's not going to work. But what we talk about, and this is something that I take you back old, we look at peripheral nerve reconstruction after injury. So we look at 6 types. So there is neuropraxia, axontomesis, axonotomesis, and then tomesis and neurotomesis and mixed types. So when we look at peripheral nerve injury, we realize that the peripheral nerve injury grows much better and faster with the help of what is called as the Mugner's nerve. Now, this is something that we have found that in the central nervous system, it doesn't work. So even cases where you take a direct transfer of the supraorbital and supratrochlear, it doesn't work. You take the auricular, it doesn't work because these are all more towards the CNS. But when you take a sural nerve, it works much better and much faster. So that is where those local transfers and something that we used to talk about earlier, I don't think they work as well as a peripheral nervous system works. This is because after a nerve crush injury, the axon regeneration in the peripheral is far superior to the regeneration of seen in the CNS. So we looked at this particular paper and we looked at our cases and we found that the nerve growth factor is something that has been added from outside. What happens to that in the tear film when you do a peripheral nervous system transplant into the eye? And you realize that as has been said in literature, the nerve growth factor contained in the tear fluid increases with the increasing ratio of the small nerve buds, the nerves that start growing there. So there are surrogate measures that you look at is vascularization, especially when you look at in children. So if your neoneuralization increases, the neovascularization reduces. So we see that at 10 months postoperative, this is Dr. Manoj Parulekar and his group from UK. At 10 months postoperative, the cornea is completely free of vasculation. So you may not be able to actually count the nerves, but you can be seeing the neovasculation. The neovasculation reduces. So what actually happens is that the nerves and the new vessels, they inhibit each other. So there is something called as neoneurization and there is neovascularization. We'll come to what induces them. We know that there are VEGF R3 and VEGF C in addition to VEGF A and B, which are important in nerve growth. We also know that PDF and DHA also enhances nerve growth. So these are all the factors that you have to give the patient even if you're doing a surgical therapy. And you know that in control and in denervated nerves, these are actually gone down and that is what is probably causing the problem. When you look at VEGF A and VEGF B, so people tell me, what do? Do you give VEGF or do you give an anti-VEGF? So there are times when I go ahead and say we'll give an anti-VEGF and they're like, but you said we should give a VEGF and here you are saying we should not give an anti-VEGF. Sometimes you're saying you give an anti-VEGF. So what actually happens that VEGF A is a factor that induces nerve growth, but it also induces angiogenesis. So whenever the angiogenesis occurs, the nerve growth is limited. It doesn't grow as much. But VEGF B, mice lacking VEGF B significantly impaired ability to repair damage to the nerves. But if you give VEGF B, the corneas of these mice, the nerve regeneration occurs, but the neovascularization does not occur. The other thing that you have to look at is Rho kinase inhibitors. So when the Rho kinase inhibitors have come in, we have started using this and we use that in a particular eye in which we have done a neurotization. The results are much faster and much better. So we have looked at whether this really plays a role. This was incidentally used because the patient had glaucoma and we thought that the keratoplasty had a glaucoma in it. But then we realized that it grew much faster than what it used to grow in the other cases. So we realized that Rho kinase inhibition is essential during in vitro neurogenesis and promotes the phenotypic rescue of human-induced pluripotent stem cells. So these pluripotent stem cells, so when we talk about neovascularization, neonization, there are pluripotent stem cells out there which may become a nerve, which may become a vessel. So you really want to rescue the nerve kind of a pluripotent stem cells, you really need to do Rho kinase inhibitor in addition to the VEGF B. Then going to the techniques which we are using in neurotization, we spoke about the medical techniques, we are now talking about the surgical techniques. There are various techniques that many people have looked at, but then you want to look at specific things that you look, this is the nerve distribution, and you look at the nerve, each nerve is like a fascicle. Each fascicle has a perineurium in which in that each fascicle there are multiple endoneurium which is covering one single nerve. So this when you are connecting, what do you want to connect? You want to connect the whole thing, you want to connect each small things, what do you exactly want to do? So we looked at whether this is a recent paper, this has come in I think this year 2020, and it talks about porcine nerve connector, and when you use these nerve connectors, we realize that we also tried using the nerve connectors, the results are much better, but it doesn't seem to make any difference in terms of time. So if you look at the epineural versus the fascicular repairs, The epidural are less exact, whereas the fasciculars are better alignment, and but it will need a little more dissection. We also looked at robotic, and we tried doing the robotic, which was initially introduced by Dr. Bosier at Ramses. And so I'm sitting right now in Apollo Hospital, and we have the robotic surgery here. So the future is here in robotic. The advantage is that it is much precise. You get much more magnification, tremor cancellation occurs. So you can do one small single nerve together also. Now you look at what we are doing, whether we are doing the right thing. You look at artificial intelligence and machine learning based on reinnervation. You look how AI can assess what we did. So you take out exact steps and figure out. So there are times when we have done a corneal neurotization and one segment, the epithelial defect remains persistent. The other segments, the epithelial defect is gone immediately. So what is it that we did wrong at SL? So we took 4 nerves and we put it in 4 different directions. But the last direction which you did, you go back to the surgery, you pick out the steps, and you realize that you ended up crushing the nerve. So this is something that you do it and you put it into other cases and you try to figure out what went wrong. And you look at big data, we are connecting to all other people around the world who are doing that. And then we are using this to teach people how to do this reinnervation. So when we look at robotics and we look at the health technology, and we realize that there is no clear-cut evidence that robotic, but now since coronavirus has come in, we realize that robotic might be sensible because you don't want to put your hand into things like that. So this might be an investment which might be worth it, because they are using robots even for giving food into OPDs and wards. So the other new things that are there is the ExoGuard nerve protector, which protects the nerve around, so nothing happens when the patient rubs his eyes or something like that. This is like a very small nervelet that has been connected there. You have an allo nerve grown over a substrate. So you have an allo nerve graft biological substrate where it grows. So these are the new advances which has come in terms of corneal neurotization. Those are my references. And that's my email address, and those are my mobile numbers. Anybody is interested, we are actually going around anywhere in the world and making teams do this. So we have achieved success at 6 centers in India, and around overall another 5 centers in around the world. So there are 11 centers where we have intervened and we have started this, but there are 18 other centers which are doing this besides us. So neurotization, yes, is the way to go. Neurotization, yes, another year later, and I might say, sorry, let's not do it. The drugs are much better. So we have to be a little sensible and very ethical and say that now the drugs are working better, maybe we stop doing the thing. But the reason why we are doing this surgery and we are trying to do things and try to figure out here, that when you're doing this, you're trying to figure out, and from these surgeries and what you see in this result, you figure out that this is the factor which grew. This is the factor which came out. So that is something you could now make it into a drug. So thank you. Thank you very much for giving me this opportunity. Thanks a lot. God bless you.
Thank you, sir, for this very, very interesting talk, and a lot of new concepts we got to know today about neurotization. Of course, we have read it in the books, but to actually listen your first-hand experience is very interesting. The whole concept. Thank you, sir. So now I think some of the other speakers are also here. Dr. Rakesh Rai, his talk on digital vision syndrome. Is he here? Do you want to take that talk, Dr. Rakesh Rai? I think he's also not here. Then Dr. Shikha Jain.
Yes, Dr. Nidhi.
Do you want to start your talk? You can take. She's going to talk about Stevens-Johnson syndrome. Dr. Shikha Jain.
Yeah.
So,
so are my slides visible?
Yes, yes, the slides are visible.
Okay, so at the outset, I would like to thank DOS for giving me this opportunity, and I'm talking about Stevens-Johnson syndrome. So Stevens-Johnson is a severe immunological dermatobullous condition with keratinocyte death and epidermal necrosis. So Stevens-Johnson and toxic epidermal necrolysis are actually two ends of the same spectrum. The annual incidence may be only from 0.4 to 7 cases per million population, but with people sitting in hospital settings with multi-speciality departments, this is a quite common occurrence. So when we look at the difference between Stevens-Johnson and toxic epidermal necrosis, SJS has involvement of less than 10% of body surface area, while 10 has involvement of more than 30% of body surface area and is essentially more severe.
It often represents an idiosyncratic reaction to systemic medications like sulfonamide antibiotics, anticonvulsants, beta-lactam antibiotics, and a host of other drugs. The skin lesions may be some purpuric macules like as shown in this picture, and this is where the role of ophthalmologist comes in. There is involvement of at least 2 mucosal sites, the ocular being the most common. So acute ocular involvement occurs in 50% to 88% of cases. It can range from meibomitis, conjunctival hyperemia to pseudomembrane formation and the sloughing of entire ocular surface epithelium, including tarsal conjunctiva and eyelid margins. So if untreated, the normal course of event is with conjunctival ulcerations, there is fusion between the bulbar and pharyngeal surfaces with development of symblepharon and enkyloblepharon, which leads to ocular motility restriction on one hand and tear film disruption on the other. The tarsal conjunctival scarring leads to eyelid malpositions, punctal occlusions, and keratinizations of the lid margin, tarsal and bulbar surfaces. The keratinized eyelid surface leads to chronic corneal inflammation and development of neovascularization, limbal stem cell deficiency, scarring, melting, and eventual perforations. There is also a severe dry eye because Stevens-Johnson affects all the 3 layers of tear film. Because of the scarring in pharynxes and lacrimal gland ducts, the aqueous component is affected. There's loss of conjunctival goblet cells and meibomian gland inspission and atrophy, leading to deficiency in lipid and the meibomian layer. So acute ocular manifestations of SJS can lead to chronic ocular sequelae with visual significance in at least 1/3 of patients. So what do we do? Prevention is always better than cure. So there are multiple windows of opportunity for an ophthalmologist in the acute phase and as well as the chronic phase. In the acute phase, there should be a prompt and detailed ophthalmic evaluation. Fluorescein staining of the surfaces is must to not only delineate the corneal epithelial defect, but also the conjunctival, bulbar, and eyelid margin defects. Aggressive treatment is indicated and the patient needs to be re-evaluated in 24 to 48 hours as per the clinical situation, as it can change rapidly. There are some red flags which need to be taken account. Eyelid margin involvement, any corneal epithelial defect, any conjunctival defects or pseudomembranes. The patient needs to be evaluated daily during the acute stage. So that when we come to the treatment, it is mainly local ocular therapy, as the systemic therapy has shown to be, the results have been published as equivocal. The local ocular therapy consists of topical drops as well as ointment steroids, prophylactic antibiotics, lubrication, and saline rinses to remove inflammatory debris. This was a review article published in 2016 for acute and chronic complications in SJS, and they graded the disease with no ocular involvement where only artificial tears were advocated, for grade 1 where there was only hyperemia, antibiotics, steroids, and lubricants were indicated, while in grade 2 and 3 with any kind of epithelial defect, be it marginal lid margin epithelial defect or surface membrane defects, all these therapies in addition to amniotic membrane transplantation had to be considered. So amniotic membrane in SJS has antimicrobial immunomodulatory properties and promotes epithelialization, but it is important to remember that the entire ocular surface along with the eyelid margins needs to be covered and should be done as early as possible. So this is a short video of a patient presenting with acute SJS for whom we did an amniotic membrane transplantation. So the eyelid margins, they were debrided of any necrotic debris and inflammatory pseudomembranes. As we can see, there is a large corneal epithelial defect. We debrided all the necrotic membranes over the surface and some pseudomembranes or inflammatory membranes that we found. This was followed by applying amniotic membrane with glue. It is important to remember that although amniotic membrane is adequately sticking only to the de-epithelized surfaces, we avoid doing any more further de-epithelization in these patients as they already have epithelization issues. So we may need to put in some sutures over the cornea as well as the conjunctival surfaces for better adherence of the amniotic membrane. These were then applied over the lids as well. and finally secured with bolsters. So coming to the chronic complications, I'll not be talking about them in detail because I believe the subsequent speaker will be talking about them. We have eyelid malpositions, misdirected lashes, dry eye, persistent epithelial defects, lid margin keratinization, and most importantly, limbal stem cell deficiency. The treatment for all of these was summed up in this article. So in conclusion, SJS is a severe, potentially blinding disorder. There are several windows of opportunity in the management of SJS, both in acute and chronic stage, which, if missed, result in irreversible ocular damage. Thank you.
Thank you, Dr. Shikhar. This was a very interesting talk. And as you rightly pointed out, it's a rare disorder, but yes, it can be, potentially devastating for the patient. So early management and appropriate management, both, you have highlighted that they play a very important role in this rare disorders. Thank you. Our next speakers, I think Dr. Rakesh Rai, is he here? Is he Dr. Rakesh Rai? Dr. Ruchita is not here. Dr. Dheeraj Prasad, I cannot see here. Then Dr. Saurabh Chaudhary. Dr. Rakesh Rai is here, but I don't know. Dr. Rakesh?
Hello?
Yes,
Hello?
yes, we can hear you.
Dr. Rakesh, just I want to the 10 minutes only 2 minutes.
Do you want to start your talk now?
Yeah, after 5 minutes.
After 5 minutes. Okay, no
Okay.
problem. So, Dr. Shreyas is also not here. Dr. Ramamurthy. And so maybe we can wait for some time for the other speakers to join because I don't think any of the other speakers are here. Meanwhile, if anyone has a question for the other speakers, then we can have some discussion on any topic if anyone wants to ask any questions. Okay, I think Dr. Ramamurthy is here. Sir, are you with us?
Yes, madam. Please tell me.
Do you want to take your talk first?
Yes,
Because
madam.
we are waiting for the other speakers to join.
Yes, madam.
Meanwhile, you can take your talk. Dr. Ramamurthy is going to talk to us about how to manage the sequelae of chronic Stevens-Johnson syndrome. So we'll be taking over from the previous talk, and this will be like a continuation. Yes, you can start your talk.
Thank you so much, madam, for having me over. And at the outset, I would like to thank everyone, the organizers of DOS, Dr. Subhash Jade sir and Dr. Namrata madam also for inviting me over. It's a real pleasure to be here. And today I'll be quickly taking you all over through the management of the chronic sequelae of Stevens-Johnson syndrome. So essentially, if you see, Stevens-Johnson syndrome is an acute, devastating episode. But one thing that you can see in this picture, that despite the terrible periocular changes that you're seeing, the cornea is absolutely pristine and has the natural normal luster. What unfortunately happens over a period of time in the post-Stevens-Johnson syndrome is essentially that there is a migration of the anterior lid margin, the keratinized epithelium, which goes over into the posterior margin. And that creates a kind of keratinized rough surface, which abrades against the cornea and causes a triad. That is, the initial episode itself is causing a surface damage leading to dry eye. Then you have the posterior migration leading to lid margin keratinization. The combination of both dry eye and lid margin keratinization leads to a secondary limbal stem cell deficiency. And the management of this triad is exceedingly important. Now, sometimes you may have a keratinized epithelium keratin, which is as obvious as this, but sometimes it might be very subtle, just minimal scarring, just migration. If you stain it, you'll see that unique staining pattern of the keratin, and you'll be able to notice that this roughened margin is what is constantly abrading against the cornea and causing a problem. So this is just a case example of a patient. If you can see that the cornea is very edematous, densely vascularized, fairly keratinized lid margins, and that has caused this picture of secondary limbal stem cell deficiency and scarring. Now, what really helps, and if there is one thing we want to take home from this talk, is that these patients, when treated at the appropriate time, can benefit greatly for the rest of their life from a simple procedure of lid margin mucous membrane graft. So essentially what we are doing here is to replace the keratinized lid mucosal margin with the lid keratinized margin with a buccal or a lip mucosa. We generally prefer using the lip mucosa because that is usually a little thinner, the amount of fat content is lesser, and cosmetically more acceptable when you do this procedure on the lids. So we thin it down adequately, and then subsequently the entire keratinized margin along with the scarred portion of tarsal conjunctiva is replaced by this lip mucosa. And this can be sutured. You can have additional fibrin glue also, which can be applied. But definitely the sutures, especially these Weichel suture, help in bringing a vascularity to the graft. And the take-up of the graft is very, very good. You have a very nice uniform appearance of the graft in the postoperative period once it has been sutured. And this can be done for both lids as well, both the upper and lower lid. And as you will see in this picture, this patient, just a lid mucous membrane graft done, nothing else has been done. And you can see the dramatic improvement in clarity. Of course, not every patient may have this much improvement. This is essentially because this patient did not have an extreme dry eye to begin with. It was a moderately wet surface, but it was this lid keratinization which was causing the problem. And once that was addressed, the patient improved from counting finger 1 meter to 6/9 vision with just a mucous membrane graft. And that is really the value of doing this. Subsequent visual rehabilitation in a number of patients, it can either be done using a scleral contact lens. It definitely improves the vision, reduces the contact of the lids with the ocular surface, so subsequent damage also is reduced, and it works well in combination with mucous membrane grafts. So scleral contact lenses we use very commonly and does help, and in combination with mucous membrane graft is very, very good. And this is a paper showing the long-term outcomes where when you compare natural history of the lid-related keratopathy, where there is a constant decline in vision over a period of time. But with an MMG and with a scleral contact lens, not only does the vision improve, but it also stabilizes in the long run. And therefore, once intervened early, even in this is actually in a pediatric population, but it applies both for pediatric as well as adults. The vision not only improves, but also remains stable in the long run. For some patients, the LSCD might be already quite aggressive. So in a very selected population where you have stabilized the surface with the lead MMG, you have a stable surface now and with adequate wetting, it's not a severe dry eye, then you could try this with an alloslide. You could also be done post a minor salivary gland transplantation to increase the amount of wetting. However, these patients will require systemic immunosuppression because an alloslide is almost like a solid organ transplant and the risk of rejection is less. So it has to be done in very carefully, the risk of rejection is more, and therefore it has to be done in very carefully selected cases. This is an ultimate stage where you have in an acute episode where it is, let's say, a TEN, where the initial episode has been extremely severe and has resulted in this completely dermalized surface. In those cases, we could go in for a type 2 K-Pro, which is not so commonly available in India, or you could do an osteoodontokeratoprosthesis or a modified type 1 keratoprosthesis. So it's just an example of a patient who's had a modified type 1 keratoprosthesis, which has slightly longer stem, using the pannus itself as a cover, and that can also be done. But in patients, I'm not going for paucity of time, I'm not going into the surgery details, but in patients who have a thinner pannus like this and a more keratinized dermalized surface, but the pannus is not thick enough, you could replace it with a mucous membrane graft. The entire surface, you could do an ocular surface mucous membrane graft. And after this ocular surface mucous membrane graft, this can be raised and you can trephine it. And we can use what we have a modified type 1 K-Pro or an LVP K-Pro, which is manufactured by Orolab. You have a slightly longer stem, and that stem can be brought out through the mucous membrane graft after the MMG has healed. And these patients do extremely well with a very stable surface. Is there a role for systemic immunosuppression? In the long run, not really. It is an acute idiosyncratic reaction. You don't really, even after reintroduction of the offending agent, like patient has had a sulfur drug allergy, a lot of my patients, even after a sulfur drug allergy, despite that they are on Diamox after a K-Pro, even after reintroduction of an offending agent, there is no relapses or recurrence. So essentially, there is not much role for long-term immunosuppression. However, staged and appropriate management is extremely important, and we can give promising results even in such dismal situations. Thank you so much for your kind attention.
We thank you, Dr. Ramamurthy, for your very, very interesting talk on management, and you've shown the surgical video really well. It was very encouraging to see the results of that graft. Very nice.
Thank you. Thank you so much.
I think our next speaker, Dr. Rakesh Rai.
No, now I am joining.
Okay, so next we have Dr. Rakesh Rai. He will be taking his talk next on digital vision syndrome. Can you start your screen sharing, Dr. Rakesh? You can start your talk now if you are there. Yes. Your slides are visible. I think, yes, now you can go to the slideshow. The slides are visible. Is there some issue with the presentation? Your slides are visible in between. They were there, and then
Hello. Hello.
You are audible. You are audible now. Yes. We can hear you. We can see
Hello.
your slides also.
Hello.
Is there a connectivity problem?
Yes, some connectivity problem, madam.
But you are audible to us.
Yeah. Hello. Good afternoon, madam.
Good afternoon. We can hear you, Dr. Rakesh. We can see your slides also, so you can begin your presentation.
Yeah. Hello. Hello, dry eye. My presentation is the digital business syndrome. Hello.
You are audible, so we can hear you. I think others can also hear you because I can hear very clearly. So you can.
Hello. Just introduction of the dry eye, the prevention and risk factor of the dry eye, and classification of the dry eye and diagnosis test of the dry eye, and management and digital business syndrome. Management of the digital business syndrome. Definition of the dry eye. The term dry eye syndrome, according to the DWS, is the multifocal disease of the tear and ocular surface disorder. Symptoms of discomfort, visual disturbance, tear film instability, and potential damage to the ocular surface. The dry eye is the disorder of the preocular film, and that result in the damage to the ocular surface and is associated with the symptoms of the ocular discomfort. As accompanied by the increased osmolality of the tear film and inflammation of the ocular surface. Dry eye is associated with the disease ability to perform certain activities such as reading, driving, computer-related, and vision attention sickness. The prevalence of the dry eye, the prevalence of the estimate about 25 to 30 million all over the world. DE is affecting a significant percentage of population, especially those of older than the 50-year age, of more than 50-year age. The symptoms of dry eye is the pain in the eye, foreign body sensation, and redness of the eye, and photophobia, and reflex botting due to the corneal irritation. Risk factor of the dry eye, just like systemic autoimmune disorder like Sjogren's syndrome, scleroderma, and rheumatoid arthritis. Other is the vitamin A deficiency, hepatitis C, thyroid disorder, and antihypertension, and antihistaminic and antidepressant drugs. Exogenous factors are radiation therapy, chemical injuries, and low humidity environment, just like air, AC, and heating. Now, winter season is the important factor in the heating. So, mostly people using the heating in the room, and low intake of the omega-3 fatty acid. Risk factor for the dry is the female gender, especially in the advanced stage, because of the hormonal imbalance, and blepharitis, Meibomian gland dysfunction, and lag of thermus, just like in case of the accidental facial nerve palsy and proptosis, and decreased blinking. In mostly people using digital device for the long time, they have problem of the decreased blinking. I have advised my clinic for the frequent blinking and every 20 minutes. In classification of the just like aqueous deficiency and evaporation, mostly people patients are coming for the reason of the aqueous deficiency. In case of the Sjogren's dry syndrome, dry eye, and non-Sjogren disease. In evaporation factor, lid disease, mostly patients are coming of the lid disease deficiency. In case of the Meibomian dysfunction and poor connectivity of the dryness, dynametric, and low blink rate. Drug reaction like radiations, and other factors like surface disease, vitamin deficiency, and topical drug preservative. Mostly people are using the so many times of preservative drops, they cause the dryness, and contact lens bleeding also cause the dryness. And other condition is the allergy, just like dust allergy nowadays. That is the main problem. Hello.
Yes, you are audible, Dr. Rakesh. You are audible.
Hello.
We can hear you.
First line treatment. Completion of the dry eye, the corneal ulceration. In case of the prolonged dryness, corneal perforation after the ulceration. If not manage the ulcer, corneal ulcer, patient go for the perforation, and corneal thinning and conjunctival scarring. And secondly, bacterial infection. If the corneal ulcer start, the bacteria, so many bacteria prone for the infection. The completion. How to diagnose the dry eye in my clinic? That is the ocular surface staining. In dry eye disease, there is loss of protective glycocyclines and barrier due to increased shedding of the corneal and conjunctival epithelial cells. New underlying cells are able to absorb vital dye. We use the fluorescent stain. We have the in the small clinics, we have not advanced technology, but we have the thermal strips and we have the stain of the eye. In case of dryness, there is stain positive. How to diagnose tear film breakup time? We have using the tear film breakup time, and if the tear breakup time less than 10 seconds, indicate tear film instability, and a measurement less than 5 seconds, there is severe dryness. If the 10 second, moderate, and if the less than 5 seconds, there is severe dryness. And tear take, tear meniscus seen at the inferior lid margin is reduced in the dry disease. If the less than 0.2 millimeter is the diagnostic. Debris is seen on the lasers, and there may be redding, telangiectasia, and thickening of the lid margin. And other measurement is the meibomian gland dysfunction assessment. Objective meibomian gland assessment is important for the diagnosis and evaluation of the dry eye. Healthy meibomian glands discharge a transparent liquid. In case of the healthy meibomian gland, there is discharge a transparent liquid. Oil under the gentle pressure to the lid margin, whereas thick or discolored meibomian gland indicate gland dysfunction. If the discharge is transparent, there is normal gland. If the discharge is discolored, that is indicate dysfunction. And pounding of the gland surface at the lid margin may be seen due to the retained meibomian. And Shermer test, it is the more invasive than the test above. Shermer strips composed of the filter paper is placed into the lower fornix for the 5 minutes and put the anesthetic drop. Start the test to prevent the reflex tearing due to irritation by the paper. And measurement less than 5 minutes is consistent with the low aqueous tear production. There is basic test, but Shermer strip test and stain test. First line treatment for the mild eye dry disease is the apply ocular lubricants, drop, gel or ointment, depending on severity of the symptoms, prefer unpreserved and adding lipid layer stabilizer. And their tear blepharitis, treat the blepharitis, lid wiping and management irritant infection. One big causes for chloramphenicol ointment to the lid margin. And meibomian gland dysfunction, warm compression, and warming eye marks. Just advise patient for the burn compression to treat the gland inflammation. First line treatment, modify the environment to decrease evaporation of the tear, increase air humidity. If the room has where humidified, they reduce the humidity. Reduce computer use, increase frequency of the breaks for the eye test, conscious blinking, review drugs that may exacerbated eye symptoms like beta blocker, triglyceride antidepressant, and serotonin reuptake inhibitor. And NIC guidelines for the referral to the optimists are not important. Pharmacological agent for the dry eye, and so many agents are for the dry eye: carmelis, sodium prolithin glycol, sodium hyaluronate, and and other are the carboxymethyl cellulose and hydroxymethyl cellulose. We are using the carboxymethyl cellulose in the mostly patient. We are using the lubricants, so many lubricants available in the market. First is the artificial teardrop to supplement the aqueous component of the tear film, or the first line therapy for the patient with mild symptoms. For the moderate patient, we are using the gels like Equilibrium or 1430 PM. So many companies provide in the gel. Lubricating ointment is only applied at the night, because if lubricating ointment is only applied at the night, that is practically possible. If we are using the daytime, there is blending of the vision. So my patients, we have advised the ointment at the night time. Regular use of the artificial tears, gels, and ointment increase the tear film breakup time and reduce the signs of the corneal damage. Insert retained by the lower lid, like Lacrysaid, provide a release alternative to the corneal lubricant. Other drugs like topical anti-inflammatory drugs are used by the ophthalmologist. Topical, we are so many times we are using a topical corticosteroid are strongly prescribed due to the risk of glaucoma and infection and keratolysis. So we are avoiding the corticosteroid. Immunomodulator drugs like anti-inflammatory effect, such as cyclosporin eye drop, 0.05 to 1%, 0.1%, have been shown to reduce the symptoms and corneal surface damage. Other drugs like tacrolimus eye drops, we are using the some patients who are tacrolimus eye drop, and testosterone mentioned, but not using testosterone, but a book have mentioned. And autologous serum, we are using autologous serum, and self patient take the blood and prepare the autologous serum and apply it for the severe dryness. Summary: dry eye disease is the common and particularly prevalent in the older women because of the hormonal imbalance. Management of the mild disease consists of the tear supplement from the pharmacy as a first line treatment and technique to the manage mammary gland dysfunction. Patient with more burst symptoms, severe symptoms, or risk factor to ocular surface damage can assess by the optometrist referred to the ophthalmologist, the primary basic treatment. Thank you.
Thank you, Dr. Rakesh, for your talk on digital vision syndrome. And I think three of our speakers are not there. So we can end the session. And I thank all the panelists for their very interesting talks on dry eye disease. Dr. Shreyas, do you want to say something?
Thank you so much, madam. It was a pleasure being a part of the session, and really enjoyed being here. Thank you so much.
So once again, I thank all the panelists, and I think we can close this session. Thank you, everyone.
Thank you.
ठीक है. Good afternoon, everyone, and welcome to this session, Management of Aphakia. Our first speaker is Dr. Priya Narang, and she would be speaking on handshake technique. Dr. Priya Narang, please.
Thank you so much. I hope my screen is visible. Is my screen visible?
Yes, your screen is visible.
Thank you so much. So at the outset, I would like to thank Dr. Namrata Sharma for this wonderful opportunity. And I'm here and I'll be talking upon the handshake riveting technique. This is one of the methods that we employ for fixation of the intraocular lenses. So this is a technique which I published in the Journal of Cataract and Refractive Surgery. It's a handshake riveting flange technique for the Yamane method of intrascleral fixation. I'll just show the animation of how this technique moves around. The initial steps are quite similar to the Yamane, that is at about 2 millimeters away from the limbus. You make the marks and you go in, and this is a 3-piece intraocular lens. You make a flange, but after that you just compress it a bit so that you make a rivet. Now this riveting is very important because this is the essential part of the surgery, and then you just tuck the leading haptic. After that you can do a handshake technique for the trailing haptic, and you can do that. I will come up to the advantages of this method and how it actually helps and how it is actually different from the double needle technique which has been described by Dr. Shin Yamane. So this is the surgical video that I'm trying to show you for the handshake riveting technique. You have this plain aphakia here. You have done a vitrectomy. There is fluid infusion inside the eye. So about 2 millimeters away from the limbus, you make these marks. And like we do in a Yamane method, so 2 millimeter by 2 millimeter, you take a 26 gauge needle. 30 gauge thin wall needles are not available freely in this country, so we need to optimize things according to our requirements. So this is a 26 gauge needle which is taken up and it is introduced inside the eye. This is a 3-piece intraocular lens. We even do not have the regular PVDF haptics. In this country, we do not have the CD Lucia lens, so we go ahead with the sensor 3-piece intraocular lens that we use frequently with the glue techniques and other techniques. So this is the haptic, it's a PMMA haptic with this intraocular lens. So what actually we are now trying to do is this is the low-temp cautery as we do it in Yamane's method. You create a flange and then you compress it. The idea behind doing this is that you make a flange and then you just rivet it because you're using a 26 gauge needle, and you do not want this haptic to slip back inside the eye. So when you make this rivet, it actually does not slip back, and then you just push this into the eye, and then you can freely handle the trailing haptic. Surgeons across the globe, they have an issue with the trailing haptic in the Yamane method. So with this method, it actually solves all the issues of handling the trailing haptic. And then with the routine handshake technique that we do for the glue dial, you can just engage this into the barrel of this 26 gauge needle. You can feed it inside and then you can pull off as we do in the Yamane method. Now there are certain advantages with this. The first being that you do not come across the rotation of the intraocular lens, and that is what is very essential. But there are various other things also that need to be taken into consideration when you are actually doing this procedure, and I'll be just highlighting that what is the kind of the flange that you need to create for these for this technique and for other methods also. So having done this and having seen this looks beautiful, it leaves settled down. You need to go through this PR paper which explains the how do you attain an optimal flange for an intrascleral IOL fixation, because the flange formation for the PVDF haptic and with the PMMA haptic is absolutely different. It is different to the extent that the kind of flange that you are actually making is dependent upon where you are holding the tip of the haptic. Like if you're holding it at a distance of 0.5 millimeters from the tip, the flange formation is different. And if you hold it at 1 millimeters from the tip of the flange, again, it's a different kind of flange that you are going to attain. So attaining an optimal flange is actually very essential, because this is what prevents the slippage of the flange or slippage of the haptic inside. So what we try to do is that with this PMMA haptics, we just try to make a rivet, and that is what it prevents. It's slipping back, and we have also shown it on OCT that, you know, it beautifully gets engaged into the scleral wall, and there is neither protrusion nor there is a slippage inside the eye. So the advantages with doing this is that, you know, you have a 26 gauge needle, which is widely available. You have a sensor piece 3-piece IOL, which is available. You know the handshake technique. It facilitates the trailing haptic maneuverability, and you have a better orientation of haptic, so you don't encounter any problem in tucking the haptic, and riveting it definitely prevents the haptic slippage. So this is just a kind of recent update that I actually wanted to pass on through. And thank you so much. If there are any queries, you can email me at my email ID. So thank you so much for this.
Yeah, thank you, Dr. Priya. And if the attendees have any questions, they can put it in the chat so we can ask. And the next speaker is Dr. Shah Nawaz, and he would also be speaking on modified Yamanese technique. Dr. Shah Nawaz, please.
Good afternoon, everyone. So good afternoon, everyone. I'm Dr. Shah Nawaz, consultant GMC Srinagar. I'm going to present my initial experience with modified Yamane technique of SFIL. And I'm highly thankful to Dr. Namrata Sharma and DOS for giving me this opportunity. Various techniques of implantation in presence of compromised capsular bag have been described, like AC lenses, iris fixated lenses, or scleral fixated IOLs. AC lenses are very easy to insert and have comparable results to other secondary IOL procedures. However, the disadvantage is that the AC, in very shallow AC, it is not possible to do it, or when there is a lot of trauma to the iris. Also, iris fixated IOLs have been successful, and there are two basic types, anterior and retrofixated. In the recent times, the retrofixated IOLs have shown better results because the AC is deeper and there is lower chance of corneal decompensation. However, higher rates of dislocations have been noted. In scleral fixated IOLs, suture fixated IOLs have been widely used, and because of less incidence of complication and very long-term effectiveness. However, delayed IOL dislocation to suture breakage has been a problem. With the advent of newer suture materials like Gore-Tex, this may be circumvented. Gabon in 2008 was first to describe the sutureless technique of SFIL by fixing the IOL haptic intrasclerally. And Agarwal developed a glued IOL technique which was widely used throughout the world and has very good results. In 2017, Yamane described the flange IOL technique of SFIL, and it gained popularity among the surgeons in the recent years. There was a comparative data study which was done by Kilker in 2018, which compared the glued IOL with the flange IOL, and both were comparable in terms of visual outcomes. However, flange IOL took lesser time and less damage to the haptic end. In our study, we took FAQ patients due to complicated cataract surgery, trauma, subluxation, endothelial sarcoma greater than 1,000. Patients having any ocular comorbidity were excluded from the study. Preoperative characteristics such as FAQ and any history of previous surgical procedures like any surgery were recorded. A complete ophthalmic examination was done. A total of 25 cases were done, and mostly it were males, and the mean age of the patients were 63. Etiology of aphakia, most were the complicated cataract surgery. In the 16 eyes were, and 4 a primary IOL was done. In 12 cases, a secondary IOL was done. In 7 cases, already a PPV was done for drop nucleus, cortex, or IOL. In 9 cases were of traumatic or spontaneous IOL subluxation. The procedure was done under periorbital anesthesia. Scleral tunnel was made in most of the cases at 12 o'clock, and angle sclerotomy at 1.52 mm was done, followed by putting a 3-piece IOL in the AC, which the haptic of the IOL was fed into the lumen of the 26 gauge needle with the help of 23 gauge forceps. Then the tip was cauterized with the help of thermal cautery and a flange was made. Similar steps were done at 9 o'clock, 180 degree at 9 o'clock. And the IOL haptic was stuck into the sclera. This is a case of Marfan syndrome in which I had planned lensectomy plus anterior vitrectomy plus scleral fixated IOL. Capsular access has been done and the back is fixed with the iris here and lens aspiration has been done. A complete anterior vitrectomy has been performed. Angle broadening entry has been made at 3 o'clock. The IOL is placed in the anterior chamber and the haptic is feeded with the help of 23 gauge needle into the lumen of the 23 gauge needle. Then it is pulled out and the end is cauterized. Similar steps performed at 180 degree from the main entry point. The haptic were pushed back. This is the case. In this case, I noted more than 270 degree of subluxation intra-op. So I converted the case and removed the lens and secured the wound and did an anterior vitrectomy. Then I decided to do SFIL in this case. And I placed an AC maintainer and did the steps of Yamane technique. So Yamane technique can be performed even primarily when there is a complication intra-op. So one is very comfortable doing it. This is a case of traumatic aphakia with traumatic matrices. And here I did a Yamane technique of SFIL along with I did a iris repair in this case. The iris repair, I performed a single pass 4-throw pupilloplasty. So Yamane technique can be very easily and comfortably combined with other intraocular procedures and gives very good results. Intra-op complications in small people, I did face some amount of difficulty while doing this technique. In one young patient where white to white was very small, the haptic broke out. So in that, I had to expand the IOL and I did a glued IOL in that case. Visual outcomes were very good. Most of the patients attaining 6/9 vision and the follow-ups. IOP, the endothelial cell count were not much affected. Post-operative complications, hypotony was seen in 2 cases, and the leak was from the main wound, the scleral tunnel, and it was sutured. And hyphema was seen in 3 cases. There was mild hyphema which resolved spontaneously. Elevated IOP was seen in 4 cases, which was medically managed. Vitreous hemorrhage was seen in 3 cases, which resolved in 2 to 4 weeks. Severe AC reaction was seen in 2 cases, and which resolved after topical medication. CME was seen in 1 case, and mild decentration was seen in 3 cases. However, no IOL has to be expanded. So all the results were comparable with other flying trial studies and had very good results. So in conclusion, it is a very easy procedure, has a very simple learning curve, and it's very effective and has reproducible technique. There are a lot of variations to this Yamane technique, like the conventional one, the Brian Kim method. However, it is advised to everyone that one should know all the techniques and find out which suits best in their hands, as there is no documented superiority of any of these procedures. Thank you.
Thank you so much, Dr. Shahnawaz, for demonstrating your modified technique. And our next speaker is Dr. Ashwin, but I think he's not available. So I would invite Dr. Sameer Narang. Dr. Sameer, please. Glued IOL with SFT in traumatic cataract.
Good afternoon, everyone. First and foremost, I would like to thank DOS for giving me this opportunity to speak on this topic. I'll be speaking on glued IOL with SFT or single pass 4-throw pupilloplasty. So I'll just. Yeah. Is my screen seen? Hello.
Yeah, your screen is visible. Yeah,
Okay.
Your screen is visible.
Okay. As we all know that there are different techniques of pupilloplasty. The Sipser's knot, the modified Sipser's, the McCannel's, the pupillary encirclage technique, or last but not the least, the single pass 4-throw pupilloplasty. So of late, this single pass 4-throw pupilloplasty has become very popular. So why SFT? First, because it is very relatively easy to perform. It is very less time consuming. You have to pass the needle through the anterior chamber only once, and so there is less manipulation, and so less iritis and less uveitis. It can be used in traumatic mydriasis. It can also be used in Ureta-Zwalia syndrome. In Ureta-Zwalia syndrome, what we have is we have a dilated pupil with slight increase in the intraocular pressure. So what happens? It serves double purpose. It also decreases the size of the pupil, SFT, as well as you are pulling the iris from the periphery towards the center. And as a result of this, the aqueous outflow increases. And so there is also a decrease in the intraocular pressure. It is for the same purpose that many surgeons are now using this technique for angle closure glaucoma. It can also be used, we are all using it with the glued IOL in high myopic cases, because in high myopic cases, in many of the cases, we see pupillary catch. So for this, we use this SFT with glued IOL in high myopic eyes. And now Dr. Amar is also doing pinpoint this pupilloplasty in cases of high astigmatism like post PK, RK, and in keratoconus, in which the patients get beautiful vision after this pinhole pupilloplasty. I'll just show a video. Now, this is a case of traumatic aphakia with mydriasis who was referred to us for glued IOL. The lancectomy was done by the retina surgeon. Here, as is the rule, we have to make two scleral flaps, partial thickness scleral flaps 180 degree apart, because if they are not 180 degree apart, then we will get a decentered IOL. After making the flap two sclerotomies 180 degree apart, we have to do a good anterior vitrectomy with tricot. At all the time, we have to put infusion in the eye, which can be in the form of anterior chamber or the trocar cannula. I prefer the anterior chamber maintainer. Now, after two sclerotomies, these are made with the main incision, corneal incision. We insert the three-piece sensor IOL. So we don't pull it immediately. We allow the whole IOL to unfold first, and then with the MST forceps or the glued IOL forceps, we just take the leading haptic out. And now you see, this is a high myopic eye. So you will see what problem I face. So here I am taking the leading haptic out of the sclerotomy wound. Now, the second haptic, the trailing haptic, I put it inside. And with the handshake technique, I try to bring it out from the sclerotomy wound. Here, see what happens when I try to bring this haptic out. The first haptic, it slips inside. This happens because it is a high myopic eye and I should have gone for vertical glued IOL. But anyways, now I have to treat it. So here again with the handshake technique, I'll bring the first haptic, the leading haptic, out again from the sclerotomy. This is the handshake technique which Dr. Amar Agarwal and Dr. Priya, they have described. And with this technique, now both my haptics are now out. So now you have to make the scleral pockets on both the sides, the Gabor-Chariot pockets, and you have to tuck the haptics inside. This tucking is very important because this tucking is what gives stability and strength to the IOL. So the tucking has to be good, and you have to tuck 2 to 3 millimeter of the haptic inside on both the sides. Okay. Now you cannot leave the patient like this, because you see, if you leave the patient, there will be a lot of hellos and patient will never be satisfied. So here I plan a SFT and or single pass 4-throw pupilloplasty with a straight needle, 9O or 10O Prolene. You pass the needle from the proximal iris, and from the other end you take it out. You can do it by the railroad technique only. From the other side, you can pass the 26 number needle and just take out the straight needle outside. So you pass, this is the single pass, you see, single pass. Now what I'll do, from the first proximal paracentesis, I'll pass a hook, and now I'm making a loop, and this loop I'm pulling it outside. Yeah, this is the loop, and it comes out to the paracentesis. Now through this loop I am passing the thread suture 4 times. Okay, right, 1, 2, 3, and okay, 4 times. So after you pass this suture 4 times, you have to gently pull the suture from both the ends. If you pull it with a jerk, then there are all the chances that iridodialysis will happen, or cheese wiring of the iris may happen. So you have to pull it gently. See, as we pull the sutures, the irises, they are coming together. They are approximated. The proximal and the distal. So here you take the first SFT. Now with the micro scissors, you cut both the ends of the suture. Now we need to take a suture from the lower end also, as you can see. So again, I pass the needle from the proximal iris and then from the distal iris, and through the railroad technique, you take out the straight needle out from the opposite paracentesis. Now again, same way, with putting the hook inside, you make a loop, and again you pass the suture through the loop in the same direction. That is important, 4 times. So this is 1, 2, 3, and 4. And then you pull both the sutures and see how beautifully the iris they come together. So you can take as many sutures as the surgeon wants. If you want to make the pupil more small, you can take 1 more suture. So in this, I think it's okay. So you switch off the infusion, and then you put a air bubble so that there is no hypotony. And this is the glue. This is the fibrinogen and the thrombin glue. With this, we glue the scleral flaps and also the conjunctiva. And you can take 1 or 2 sutures on the clear corneal wound as required. Thanks a lot. Thank you very much. Thank you for your attention.
Yeah, thank you so much, Dr. Sameer. And our next speaker is Dr. Parth Rana. Dr. Parth?
Yeah.
Yeah.
Hello,
next
sir.
speaker is Dr. Parth. Yeah, hi. And he will be speaking on scleral toric IOL.
Yeah. Am I audible now?
Yeah.
Yes.
You are audible.
Yes.
Please share your screen.
Yeah. Okay. Is it visible?
Yeah, visible.
Yeah. I would like to thank DOS and Namrata Sharma ma'am for giving me this opportunity. I would be showing my patented scleral tuck IOL here. So here I am sharing it.
We have no financial interest whatsoever. Just think of a capsular complication in cataract surgery, where you have already taken a lot longer than usual, and now you have to place the tedious and time-consuming scleral fixated IOL. It is a nightmare, right? Not anymore. Presenting the revolutionary patented design and uncomplicated effortless technique of the Rana and Shah's self-sustaining scleral tuck IOL. This is the evolution of the scleral fixated lens. Scleral tuck IOL is designed to simplify the complex surgery of scleral fixated IOL and reduce the cost significantly. This design of next generation of scleral fixated intraocular lens is inspired from the price tag label on clothes. Scleral tuck IOL is made up of 4 different parts: flipper, neck, haptics, and optic. Flipper is the major innovative idea and a crucial part in the design of the lens. It is meant to come out of 20 gauges sclerotomy and stay out in scleral pockets. Flipper is thick and partially rigid to stay out of sclerotomy permanently. It has an eyelet by which we can engage the flipper with 20 gauge vitreous forceps, and it can also be used at the time of uncertainty to suture it on sclera. Flipper is larger than 20 gauge sclerotomy. So, once it is out, it can't go back in. And before closing, it should be checked twice that flipper is completely out. Neck. It is meant to stay at sclerotomy port. It is a bit smaller than the size of 20 gauge. It is quite stretchable and is helpful in the placement of flipper and also at the time of checking position of the flipper. It is transition between flipper and haptic. It is stretchable and gives strength and support to the whole lens. Haptics. These haptics are stretchable and can take shape accordingly. Haptics in this lens are 4-point fixated and not like conventional lenses with 2-point fixation. Due to 4-point fixation, it is highly stable and pseudophacodonesis is very minimal. Optic. Optic in scleral tuck IOL is 6 mm in size, which is large enough to cover even a mesopic pupil and even a case of misalignment of sclerotomies as well. It is foldable and can be easily inserted from phaco main port. Implantation of scleral tuck IOL. Placing of the scleral tuck IOL is an effortless technique.
Here we are making one main port, and
we inject the IOL in anterior chamber with injector and place it on iris. Lens is then rotated in horizontal position, and then the eyelet of the flipper is engaged with the help of 20 gauge vitreous forceps and flipper is pulled out of sclerotomy. Same thing is repeated on the other side. Once flipper is out, it is checked twice. Now let's see the real-life implantation of the scleral tuck IOL.
Here I am showing you the technique, how we are doing it. Here as first haptic I have injected through a SICS tunnel, and we are pulling it out from the 20 gauge sclerotomy which we have already made. It was a simple handshake. When we are injecting it, the first haptic, it's a simple handshake, and the other side also, as you can see here, just I am holding the eyelet and I am pulling it out. Once I am pulling it out, the flipper is out of this sclerotomy and the surgery is over. It's quite simple. And as you can see, I am pulling this flipper like this much, but even though due to stretchability of neck, it comes out nicely. There are no issues in that. And once this flipper is out, the surgery is over. It hardly takes a few minutes, and we don't have to do typical steps for this. So surgery-wise, it's very
Advantages
small.
of Scleral Tuck IOL. No suture, no glue, self-sustaining. This is a major breakthrough in surgical implantation of scleral fixated IOLs. As the name says, it is self-sustaining. There is no need of non-reusable materials like suture or glue. Simple in design. Easy to implant. It is foldable, so it can be implanted from clear corneal phaco main port also. Minimal learning curve. Anyone with knowledge of anterior vitrectomy can do it. No need of sutures or glue, so it is cost effective. Larger optic, which is large enough to cover even a mesopic pupil and even in a case of misalignment of sclerotomies. Haptics have 4-point fixations, so minimal pseudophacodonesis. Flipper is rigid to stay in the position for longer time. Less surgical time, less corneal damage, hence good post-op outcome. Rana and Shah's self-sustaining Scleral Tuck IOL is the next generation of scleral fixated IOLs. It is safe, simple, effortless, cost-effective, and reliable alternate to contemporary scleral fixated IOLs. It can be implanted by any anterior segment surgeon with little knowledge of anterior vitrectomy. Scleral Tuck IOL is a revolutionary innovation in the field of scleral fixated IOL surgery and will change the course of the future.
Thank you. My video is over. It's a quite simple technique, and if anyone has any questions, they can just mail me. Thank you.
Yeah, thank you, Dr. Rana. Are these lenses available? Which company is marketing these lenses?
Omni is marketing it. It's freely available now. We have launched it a few months ago. Now it's available in the market.
Okay, thank you. Thank you for the very nice presentation. Yes. Our next speaker is Dr. Sri Ganesh. I think he's not attending, so his video will be shared. So please share the video.
Capsulotomy fixated IOL. I would like to share my presentation. I am a consultant for Carl Zeiss Meditech and Biotech. So there are many advances in modern cataract surgery, like newer generation formulas, optical biometry, which have improved outcomes. But still, you can have patient dissatisfaction after perfect cataract surgery because of refractive surprises, IOL tilt, rotation, decentration, PCO, or even dysphotopsia, where the patient has 20/20 vision but still unhappy because he sees shadows. Various capsule fixated lenses are being investigated. Some of them are bag in the lens IOL, the lentis laser lens, and the Masket ND IOL. But they have their potential limitations in removal of OVD from the bag behind the IOL, complex designs, technically difficult to manufacture, they need special instruments and injectors, and you can end up with capsulotomy tears, capsule blockade, iris chafing, or pigment dispersion. So I've designed a new type of posterior chamber IOL for capsulotomy fixated. It is a single piece open loop hydrophilic acrylic IOL. Now we have it in hydrophobic, and we are doing the investigations for hydrophobic IOLs. It is a 6 mm aspheric optic, 360-degree square edge, and oral diameter is 30 millimeters. What is different is it has two movable extra haptics at 3 o'clock and 9 o'clock position made of PMMA, and now with a different material which can swivel over a pivot. This is an animation of the insertion. It is inserted like any other IOL through a regular cartridge into the capsular bag. Once it is inserted into the capsular bag, then we take two dialers, and then we are able to move the swivel haptic over the anterior capsule and capture it in the capsulotomy. So the IOL gets fixated to the anterior capsule. This is surgical implantation of the new lens. So you can see this is a butterfly cartridge, a regular cartridge, in which the lens is loaded and injected into the capsule. Once it's injected into the capsule, then we take 2 dialers. You have to make a 4.8 to 5 millimeter capsulorhexis. Even up to 5.2 millimeter capsulorhexis is acceptable. And you rotate the swivel haptic and bring it over the anterior capsule. The same thing is repeated on the other side. And this captures the capsulotomy. And the lens is fixated to the anterior capsule. The OVD is aspirated, and you can even remove the OVD from below the IOL, unlike some of the other lenses like the Mastek lens. This is the dilated clinical photography, which shows the stable position of the IOL even at 6 months. There's no decentration, tilt, or rotation seen because the capsule is captured by the swivel haptics. We also did a UBM, which shows that the ELP is more anterior and just behind the iris plane, and there is no variation in the ELP. On subjective questionnaire, no patient reported any dysphotopsia, positive dysphotopsia like glare, halos, or reflection, or negative dysphotopsia, which is a crescent or a temporal dark shadow. And we did not have any PCO at 6 months. Potential advantages are that it is simple design, easy to manufacture and pack, standard injector through a 2.8 mm incision, no special instruments or surgical training required. You can do it either with flax or manual phaco emulsification. Easy removal of OVD from the capsular bag. You have a stable fixation in ELP, good centration with no lens tilt. Rotational stability is excellent for toric designs, irrespective of bag size. There's no or minimal dysphotopsia, no pigment dispersion, and if required, it can also be easily explanted. I presented this video, and it has won several awards at ACRS, APACRS, and we also have a US patent now for it, and we are in trials for the hydrophobic lens with different haptics, and hopefully we'll be able to commercialize this product shortly. We have also published windshield reports with this lens in IJO. Thank you very much for your attention.
Yeah, that was a very interesting video. I think do we have any more speakers here? Dr. Nevium and Dr. Ashwin, they are not present, I suppose. So I thank all the speakers and all the attendees. So this brings us to the end of this session, Management of Aphakia. Thank you so much to everyone for attending.